Bhupendra will be presenting it.
Yes. Good morning, everyone. I'm Dr. Bhupendra Yadav, Senior Resident in RPC, and thanks to Delhi Ophthalmic Society for giving me this opportunity. Now coming to our case, it's a perplexing case of unilateral proptosis. A 45-year-old female from Uttarakhand came to our OPD with a progressive outward protrusion of left eye from last 2 months, which is associated with mild ocular pain. The onset of symptoms occurred 2 months back when she complained of outward protrusion of the left eye, which was progressive and mildly painful. There was no history of heat sensitivity, sweating and diarrhea, no history of trauma, no history of chronic cough, fever and night sweat, no history of recent weight loss, loss of appetite and fatigue. There is no history of any epistaxis, no history of any systemic illness and a similar complaint in family. After the onset of symptoms, she consulted a local private clinic. Patient was evaluated and thyroid profile and CMRI, brain and orbit was done. Thyroid profile was normal at that time. Patient consulted another private doctor and FNAC was done. FNAC shows the mostly histiocytes along with numerous spindle cells. And there is also a pleomorphic nuclei as present, but no definite malignancies are seen. Features suggestive of mesenchymal lesion. Patient present to RPC and evaluated. A patient was hypertensive from last 2 years and was recently been diagnosed with diabetes mellitus. General physical examination and systemic examination was within normal limit, and in ocular examination, right eye was within normal limit, and in left eye vision was 6/18, which was improved to 6/6 with pinhole. There is a abaxia proptosis of around 6 mm, and movements are restricted in all gauges with grade 1 RPD. On proptosis workup, on inspection, there is abaxia 6 mm proptosis with inframedullary dystropia, but no obvious marks are visible, and movements are restricted in all gauges with grade 1 RPD. In left eye, there is a mild ptosis present with inferior scleral show. On palpation, there is a smooth, firm, non-tender mass present in the supralateral quadrant, and resistance to retropulsion was firm, and there is a lateral orbit rim was not well defined. So we ordered the USG orbit, CCT, Haydn orbit, X-ray chat, and routine blood investigation. In CCT, this is CCT of the patient, in which we can see the fairly refined heterogeneous hypodense lesion with lobulated margins in an extraocular space with extraorbital extension. The lesion is heterogeneously enhancing with thin internally enhancing septate. And there is a near complete resorption of the lateral wall, and there is thin rim of peripheral interrupted calcification around the lesion medially. In CMRI of brain orbit, there is alter signal intensity mass lesion at the lateral aspect of left orbit, measure around 33 into 27 and 40 mm size. There is a dissection of the lateral orbital wall with extension into the orbit, causing proptosis of globe and compressing and displacing the lateral rectus muscle medially. The lesion was iso to hyperintense on T2 images and iso intense on T1 weighted images. On post-contrast image, the lesion takes moderately intense enhancement. And USG orbit, there is a cystic lesion with moderate to high spike in the cavity. And XHH, there is a prominent hilar marking seen. A routine blood restriction was normal, except there is a raised in ESR and HbA1c level. On clinical summary, a 45-year-old female with unilateral mildly painful progressive abaxia proptosis from past 2 months. And in examination, there is a ophthalmoplegia, grade 1 RPD, firm non-tender orbital mass, and retropulsion test is firm. Later orbital rim was not well defined. In investigation, there is a cystic lesion on the USG, prominent hilar marking and chest X-ray. There is high ESR, uncontrolled diabetes mellitus, and bone erosion seen in CECT. So after the history examination investigation, these are the differential diagnoses which came to our minds. Aneurysm bone cyst is a lytic expansile mass lesion, usually occur as a sudden or incident onset and usually associated with pain, but it's a rare lesion. Subperiosteal abscess point in favor are the prominent high-level marking and uncontrolled diabetes. But point are against they mostly common arise in the setting of orbital cellulitis, particularly in the pediatric population, and hence typically present with orbital sign and symptoms which were absent in our patient. And there is Mortex test negative, and there is an absence of family history or history of TB. Interosseous hemangioma usually occur in the 4th to 5th decade of life, and there is a female preponderance. But it's a slow-growing, rare tumor, and lesion. And the absence of classic Crowdey lesion, Crowdey sign, and polka dot appearance on the CT is not seen in our patient. Hydrosis is usually present with painless progressive proptosis, and usually associated with increase in ESR. But absence of eosinophilia and presence of bone dissection are the points against the diagnosis of hydrosis. Orbital dermatitis is the most common cystic lesion, but it usually causes fossa formation rather than the bone dissection, and it's a slow-growing lesion. So the probable diagnosis we made, the aneurysm bone cyst, it could be the primary aneurysm bone cyst or the secondary aneurysm bone cyst, which occur in the setting of fibrous dysplasia, giant cell tumor, non-ossificant fibroma, chondroblastoma, osteosarcoma, and fibromyxoma. So we planned a left eye anti-orbitotomy for X-ray biopsy and sample sent for histopathologic analysis. This is the intra picture of the tumor. Here we can see the high vascular polypoidal mass within the cavity with bony resection. In histopathology finding, the excised left orbital mass shows a high-grade sarcoma with extensive necrosis. The tumor has high vascularity with evidence of bone dissection and bone formation. Immunostains are positive for smooth muscle actin, DASPins, epithelial membrane antigen, CD34, and weakly positive for SATB2. Stains for S-100 and MIC2 are negative. These histologic features are compatible with the osteogenic sarcoma. So the final diagnosis was made is left eye osteogenic sarcoma, and patients sent to ISH for starting of chemotherapy, and we order the PET scan to rule out the metastasis. So in the discussion, osteosarcoma is the most common primary bone neoplasm, most commonly arise from the metaphysis of the long bones of the extremity. Head and neck region is a rare subset of osteosarcoma, and head and neck region osteosarcoma comprises the less than 10% of all osteosarcoma and less than 1% of all the head and neck malignancies. Mostly arise de novo, but some are secondary to Paget disease, fibrous dysplasia, and radiotherapy. In cases of family retinoblastoma, osteosarcoma develop as a second tumor. Osteosarcoma of the head and neck behave differently from the extremity sarcoma. Median age is at least 2 decades higher in case of head and neck sarcoma, and risk of metastatic disease of the lung is less than osteosarcoma of the extremities. Local recurrence predominate in case of osteosarcoma of the head and neck, which is due to difficulty to obtain a tumor-free margin by surgery in the head and neck region. Orbital osteosarcoma are the most frequent in the 4th to 5th decades, present over several months with progressive mass effect, often associated with pain and infiltrative effects such as diplopia and decreased vision. Few studies have been published regarding the management of head and neck osteosarcoma. All emphasize on the importance of margin negative resection. All emphasize on the importance of margin negative resection, and the role of chemotherapy and the radiotherapy are still inconclusive. So take-home messages: in case of negative FNAC results and high clinical suspicion, biopsy should be done. Margin negative resection is important in management of osteosarcoma, and role of chemotherapy and radiotherapy in management is still inconclusive. Osseous lesion of the orbit can't stop imaging us. Thank you.
I think Dr. Bhupender has well summarized the case. I'll just give you a brief review again about the case. That we had this middle-aged female who was having a unilateral, mildly painful proptosis on examination. Just that it was very short duration presentation of 2 months. On examination, we found out that the female had a vision of 6/12 and there was a grade 1 RAPD there was ritopulsion positive with firm non-tender mass present in the lateral part of the orbit with almost complete resorption of the lateral wall of the bone. The ultrasound revealed that it was a cystic mass with some high spikes inside it, which revealed that it had been calcification, and the CCT then revealed a heterogeneous lobulated hypodense lesion, which was taking slightly contrast, and that there was almost total resorption of the lateral part of the orbit. So with all this in mind, we kept a differential of aneurysm bones is ABC and periosteal abscess, and went ahead with doing a biopsy, which landed us to have a diagnosis of osteogenic sarcoma.
Any questions on this interesting case, which is very uncommon case of osteogenic sarcoma? Like Dr. Sahil, you said mostly these osteogenic sarcomas are metastasis from the primary side, which is
right.
in the extremities, but there's the head and neck and in the orbit, osteosarcomas are very less. They account for less than 10%.
It's extremely rare because they are mostly seen in the long bones of the human body. And even in the head and neck region, they are mainly seen in the maxilla and the mandible areas. So a primary osteosarcoma of the orbit is extremely rare, sir. Extremely rare. So accordingly, the treatment protocols for head and neck also, they have a lot of difference. Multiple drug regimens have been tried, but they have not availed much of an output as far as chemotherapy and radiotherapy are concerned, as compared to the systemic ones, as compared to the long bone osteosarcomas.
And what is the response to radiotherapy, you said?
So for the systemic, the long bone osteosarcomas, they have a good response. Around 75% 5-year survival prognosis is there. However, for the head and neck cancers, they are yet the first 18 months survival with extensive neoadjuvant chemotherapy and post-operative chemotherapy have revealed good results. But after the 18 months of the prognosis about survival is very variable, sir. Multiple review articles, because the disease is very rare, so accordingly the treatment protocol have not been very much, they have been trying multiple drug regimens to get a good treatment, however it's of no much use.
And you said the newer chemotherapeutic drugs are still being tried in these cases.
So multiple drug regimens have been tried, including cisplatin, doxorubicin, and methotrexate, however with not much of a yield.
So what will be the further course of action? How?
So we had sent the patient for chemotherapy. However, after 6 months probable of the chemotherapy, because the chemotherapy duration in such patients stays from 6 months to 12 months, we lost the patient to follow-up probable. I think because this osteogenic sarcoma of the head and neck tumors have a very local recurrence. Like the systemic ones tend to metastasize, this have a local extensive progressive. So we believe that patient must have passed away, sir.
So, any comment from Dr. Bitheria, sir?
I think the findings of orbital ultrasound are not very clear. You have diagnosed it as a cystic lesion, and you have come out with a different type of mass.
True, sir.
I think orbital ultrasonography requires a long experience, and diagnosis of cystic lesion was totally wrong. So I think cystic lesions are of different types. The hydatid cyst of orbit, you see my Betharia's sign, double wall sign, that I have described, published in the American Journal of Ophthalmology 2004. And then we have a cysticercosis where you see a scolex, which is very clear cut. And sometimes we get some small cystic lesions in cystic degeneration in neurilemomas. I think these are the types of cystic lesions. So I think orbital ultrasound is a very important diagnostic thing. And John Wright never believed in orbital ultrasound, but I can tell you that orbital ultrasonography, you can diagnose neurilemoma, hemangiomas, lacrimal gland tumor, cysticercosis, hydatid cyst. So many lesions you can diagnose very nicely with orbital ultrasonography, and it needs to be practiced meticulously. In this case, 2 months only, history of 2 months, and bony erosion and all that. So diagnosis of osteogenic sarcoma was very important diagnosis. But it is a very rare case. In my long-drawn experience of 46 years in oculoplasty and orbital surgery, over 1,000 orbital surgeries done by me, I have never come across osteogenic sarcoma. So I think this is really a rare case, Thank you very much for your presentation.
So I would totally agree that ultrasound is a very important tool in the hands of a clinician, and that should be done very meticulously. Thank you so much,
Thank
sir.
you.
Thank you very much.
Thank you,
Thank you
Sahil.
for the nice presentation. And we'll take up the next case now. Next case is going to be presented by Dr. Ananya Kalignar. And the case is an unusual presentation of sympathetic ophthalmia. Yes, Dr. Ananya.
So, good morning to one and all. I'll be presenting an unusual presentation of sympathetic ophthalmia. So, on 9 January 2023, a 22-year-old female was diagnosed as a case of Axenfeld-Rieger in our OPD with secondary glaucoma in the right eye and a blind, painful eye with total corneal decompensation in the left eye. So, there was no history of trauma or any previous episodes of redness in the left eye, and there was a history of diminution of vision since childhood. So the visual acuity was 612 in the right eye, PL positive, PR inaccurate in the left, and there were no complaints in the right eye at the time of presentation. On 23rd Jan 2023, the patient underwent DLCP in the left eye because it was a blind, painful eye with increased intraocular pressure. On 24th February, the patient developed symptoms of headache, redness, pain, and blurred vision for near in the right eye. On 10th March 2023, the patient developed associated hearing loss. And on 14 March 2023, the patient presented to OPD with a rapid onset progressive diminution of vision in the right eye. So on presentation and ocular examination, the vision in the right eye was PL positive, PR inaccurate. There was congestion in the conjunctiva. There were mutton fat KPs in under the cornea with temporal and nasal peripheral anterior synechiae. There was an intense inflammation with 3+ cells in the anterior chamber and an inflammatory NVI which was present. So there were posterior synechiae which were present with pigments and inflammatory membrane over the entire anterior lens capsule. And in the left eye, there was a central leukomatous corneal opacity with a shallow 360-degree peripheral anterior synechiae in the anterior chamber and a poorly dilating pupil with a cataractous lens. So at presentation in the right eye, there was a grade 2 media haze. There was a 360-degree bullous retinal detachment with macular detachment, and there was disc edema which was present. So looking at the anterior chamber findings and this posterior segment presentation, we made a preliminary differential diagnosis of granulomatous uveitis with exudative retinal detachment. So we could think of 3 differential diagnoses of Voka and Agi-Harara disease, sympathetic ophthalmia, and panuveitis, which the etiology could be sarcoid, TB, or syphilis. So we went ahead to investigate it, and the ocular investigations, we did a fundus fluorescent angiography, an OCT, and an ultrasound. And in systemic investigations, blood pressure, serum electrolytes, serum ACE, HIV, TPHA, HBsAg, chest X-ray, an MRI brain, because as I had previously said, the patient had a history of headache, so we wanted to rule out whether there was any meningeal involvement, and an ENT consult was sent for the hearing loss, and a pure tone audiometry was advised. So the ultrawide field fundus fluorescent angiography showed dilated tortuous vessels, diffuse perivascular leakage with disc leakage, and a block fluorescence in the area of the retinal detachment. The OCT showed a neurosensory detachment, subretinal fluid with hyperreflective dots with a hyperreflective lesion beneath the retina, hyperreflective lesion at the level of RPE, splitting of the photoreceptor layer, and an increased choroidal thickness. An ultrasound was done which showed a diffuse choroidal thickening with retinal detachment in the right eye. The chest X-ray was within normal limits. The serology, the serum ACE, TPHA, VDRL, and MON2 were negative. The MRI was within normal limits. And the ENT, the pure tone audiometry, showed a severe sensory neural hearing loss in the right eye and a profound hearing loss in the left. So the treatment started was oral Vizolon, which was 40 mg because the weight of the patient was 32 mg, and oral Pantop, along with topical steroids and topical cycloplegics. Now, 8 days from the presentation, the patient still had a vision of PL positive, PR inaccurate. There's an increase in the media haze and the height of the exudative retinal detachment, and an evolving subretinal band was seen. The fundus fluorescent angiography also showed an increased diffuse perivascular leakage with disc edema, and because of this, the IV methylprednisolone 500 mg was started because of these increased severity of this presentation, and it was given for 3 days, followed by oral methylprednisolone, along with proton pump inhibitors, calcium supplements, topical steroids, and topical cycloplegics. 14 days from presentation, the patient still maintained a vision of PL positive, PR inaccurate. There was persistent exudative retinal detachment, and now the subretinal band was taking a napkin ring conformation. So a repeat IV methylprednisolone was given for 3 days, followed by oral methylprednisolone, along with proton pump inhibitors and topical steroids and topical cycloplegics. 21 days later, the patient presented with a vision of 1/60. There was a resolving napkin ring configuration and a decreased height and area of the retinal detachment. The OCT showed the resolution of the detachment, subretinal fibrosis, RPE atrophy, increased transmission of the signal because of the RPE atrophy, and a decrease in the choroidal thickness. 4 months later, which is the most recent follow-up of the patient, the visual acuity is 2/60. There is a resolved napkin ring configuration of the circumferential subretinal band with an attached retina. So putting the pieces of the puzzle together, there was a history of DLCP with vision loss within 1 month of onset. There's a history of blurring for near with headache and redness, occurrence of severe sensory neural hearing loss, total exudative retinal detachment with granulomatous anterior chamber inflammation, and a diffuse perivascular leakage with disc edema on FA. So we made a preliminary diagnosis of sympathetic ophthalmia which had occurred post-DLCP in this patient. The further discussion will be carried out by Dr. Shaurya Azad.
Okay, so why are we discussing this case? So basically there are 5 things that are different in this case. One is the diagnosis, that is sympathetic ophthalmia post DLCP, which is rare. Association of hearing loss, like integumentary signs are generally associated with VKH and not with sympathetic ophthalmia. So it can be associated with sympathetic ophthalmia as well. Then the treatment that we gave, steroids, there was no response to oral prednisolone, which is generally the most potent, and in 99% of the cases it works quite well. And then pulse therapy generally is given as a 3-day course and then followed by oral, but because it was so severe that we needed to do 2 courses, and even on maintenance because of non-responsiveness to the oral prednisolone, we had to keep the patient on oral methylprednisolone. So regarding the diagnosis, as Ananya said, that if you have granulomatous uveitis, we have a very clear-cut differentials that we have, and if we add exudative retinal detachment along with it, then the differentials becomes a little bit more slimmer. Now we have 2 things in our mind: bilateral granulomatous uveitis, sympathetic ophthalmia, and VKH both can be there. One thing that was there in our case which was different was obviously the history of trauma or surgery. There was a history of DLCP which was there a month before the symptoms came, and there was no history of inflammation any time before the surgery in either of the eye. And although there was hearing loss in our patient, still integumentary signs can be present in sympathetic ophthalmia, and it's not exclusively only in VKH. So we already know the pathogenesis, that there are some antigens which are released because of the trauma or the surgery, and then the immune system gets activated, mounts an immune response, and the sympathizing eye then starts having inflammation. So why this susceptibility? So and why do we get these integumentary signs? So one is that it is the uveal tissue. So the antigen is basically uveal, and the immunity then mounts a response against not just the uvea but also the retina and also other places where these melanocytes might be present. This is because of the common embryological development, which is the neural crest cells, which are there present in all these areas. And this particular cells may even be present in adults, like in the form of either stem cells, but their prevalence is very less. It is only 0.2 to 2%, and that might explain the reason why we have so many penetrating traumas, but we don't have sympathetic ophthalmia so frequently. So that might be the reason. Regarding sympathetic ophthalmia post DLCP, well, it is basically, as I said, that the ciliary body is the danger zone, and we don't want to stimulate it. And what we're doing in DLCP is basically physically disrupting the ciliary processes. So there might be dissemination of antigen. It is related to the total energy, the area that is involved, and the number of procedures that are repeated. And there are evidences in literature regarding the same. With regard to integumentary signs, well, as I said, that as the pathogenesis is similar in both VKH and although it is rare, it is not uncommon. It can be present, as both the ear and the uvea have the same embryological origin. And one difference that was seen in our treatment was we started off with oral prednisolone, which is actually quite potent, but however we could not get a desired response, and then we had to give a course of methylprednisolone. The patient improved for the first 3 days, but as soon as we removed and we made the patient go on oral methylprednisolone, there wasn't enough improvement, and there was this formation of a subretinal band that was there, and it was progressing. So we gave another repeat dose of IV methylpred, and then we started seeing a slow resolution that was there, and by 4 months you can see that there is complete resolution of the detachment with subretinal fibrosis. Now, why didn't the steroid work? So why was there no response to oral prednisolone, which is mostly, always effective? So it might be because that the tissue that is involved, there is hyperdependency on steroids. So maybe the tissue requires more higher dose of the steroid, or maybe we need to change the steroid that we are doing, and we change from prednisolone to methylprednisolone, which is a more potent drug. With respect to repeat pulse therapy, normally the pulse therapy is given for 3 days, but in severe cases or places where we get normal response, we can probably give it for 5 to 7 days as well. With regard to oral methylprednisolone, we generally use prednisolone, but they are similarly intermediately acting, and however it's more potent, and there is a lower dose, so we have to titrate it into 4:5 ratio. So what we had was basically a sympathetic ophthalmia that can occur post DLCP, which is rare. Integumentary signs, although might be rare in a sympathetic ophthalmia, still can be present. Delay in treatment leads to rapid progression, as we saw with the subretinal band, which was forming in a napkin ring configuration. And severe cases may have high dependency on steroids, so would require longer and repeat pulse therapy, followed by oral methylprednisolone for maintenance. Thank you.
Thank you very much for the wonderful and very rare case presentation again, because we expect always very rare cases from the RP Center. And this is one of them. And the important point to what I could observe in this particular case was this patient actually had the infection in the cornea, or some other form of the disease in the eye. So what exactly this patient had previously in this particular eye, left eye?
So the patient having Axenfeld Rieger and having secondary glaucoma, for which the patient was treated because it was a painful blind eye. So patient underwent DLCP.
But this eye never had any injury or any
no,
other
did not
problem?
have any injury, and neither did the patient have any history of inflammation as such or previous episodes in the past.
So just the isolated DLCP, suppose this patient never had any injury or this painful blind eye, and if you do only DLCP, is it possible still to happen?
Yes, that's exactly what I showed in the slides, that there are quite a few number of case reports as well as case series which are there, that post DLCP there is a chance that there might be sympathetic ophthalmia, and hearing loss is not association which has been seen post DLCP, but yes, sympathetic ophthalmia post DLCP has been seen in quite a few. So cyclodestructive procedures and as well as DLCP per se have shown to be associated.
So just for the benefit of the house, at what stage and at what points you said that it is sympathetic ophthalmia, not VKH?
Okay, so as I said that first of all, the first thing that we need to differentiate is the history of either trauma or surgery, or any procedure. So these two things have to be first on, and we had a history of DLCP. So again, that was one thing. And when you have a granulomatous uveitis with an exudative retinal detachment, then most commonly you see in VKH, and the next to it is sympathetic ophthalmia itself. And when you have a negative history of having no inflammation in the other eye or no previous episodes, then obviously the most likely is DLCP. And DLCP specifically, as I said, is actually targeting the ciliary processes, and ciliary body is actually a danger zone which might lead to the release of the antigen and then the whole cascade.
But this patient had a good visual recovery after the treatment. So what is the prognosis of visual recovery if you compare VKH and sympathetic ophthalmia?
So it all depends upon when we start the therapy. So earlier we start, the better visual prognosis that we'll have. So in this patient, we had a delay because we gave it for 1 week of oral prednisolone, but the detachment did not resolve. So we had to give an IV methylpred after that, and then only it started showing improvement after 2 doses of IV methylpred. So the prognosis is guarded because even now the patient has only 2/60 vision, but because the patient is non-eyed, 2/60 vision is quite enough for the patient.
Yeah,
Thank you.
Dr. Shaurya.
So one question.
Like
one
said,
question.
okay, the incidence, yeah, Dr. Narang, please.
Yes, sir. So a simple question I want to ask. So what is the exact cause of sympathetic ophthalmia? You just told, but I don't really get it. Can you repeat that? What is
Yeah, Dr. Narang, he's already told that the sympathetic ophthalmia, as we understand from our teaching, is that it occurs either after penetrating trauma or intraocular surgery. The incidence after intraocular surgery is quite less, just 0.01%. But after penetrating trauma, the incidence is quite high, 0.2 to 0.5%. But after procedures like DLCP or cyclophotocoagulation, then the incidence, it is very uncommon. And as he said, since it is directed to the ciliary processes, there is compromised immune privilege status of the eye, where there is exposure of the previously sequestered uveoretinal antigens to the systemic immune system of the eye. And like he's pointed out. But what I found from the literature, it's common with some HLA typings, so where it is quite common, like HLA AA11, B40, DR20, it's quite common. Was HLA typing done to find out, since it's a very uncommon case?
We didn't know the patient was very poor, so we did not do any HLA typing in the patient, but yes, there has been shown a genetic predisposition. So why does VKH occur only, or sympathetic ophthalmia occur only in a specific set of patients? That is because of the genetic predisposition that is there. So like I said, that one is the neural cast cells and the stem cells, which might be the ones which are getting stimulated in select few and then leading to a sympathetic ophthalmia. Likewise, even genetic predisposition of the patient might be the reason why some people are having sympathetic ophthalmia and some are not, although the number of cases of penetrating trauma are quite high.
Exactly. So what is the mechanism causes? Okay, sir. How does it occur? How exactly the other response?
Like he said, some uveal antigens. Okay. Now they are exposed to these are sequestered uveoretinal antigens. Okay. Now they are released, and these uveoretinal antigens are exposed to the immune system of the body. So that is why this severe inflammatory response occurs. And the antigens he's reported are S antigens, recoverin, rhodopsin, melanocyte associated tyrosine. Various antigens have been implicated. And Dr. Shaurya, they say that like you have now regained the vision of 2/60, but there is condition called recurrent and chronic sympathetic ophthalmia also, where you need to try the immunosuppressants like chlorambucil, cyclophosphamide, etc., or even intravitreal injections of TCA and infliximab.
Yeah, sir. So
they go to uveal tissue only or other eye? No, nowhere else. These antigens specifically attack the uveal tissue of the eye, and nowhere else they go.
No, sir. Uveoretinal antigens, basically. Yes.
Thank you.
Yeah. Now I think we have had good discussion on such an uncommon case, Dr. R.
Thank you very much. Thank you for the nice case presentation. And now we'll invite Professor Titiyal. He's going to give a clinical talk on phacoemulsification in complex situations. Professor Titiyal.
Thank you, Chairpersons. And first of all, I'd like to welcome all of you on behalf of RP Center family for making this monthly meeting excitable with so much a good discussion, not only for GVM, for cases also. And thank you, NOS Executive, for giving this opportunity. I'm going to take you through the common scenarios. Sometimes looks simple, but if dealt properly, you can have a very good result in these cases also. No financial disclosure from my side. So this is case number 1. A young lady came for a surgery in right eye with toric implantation, because you can see AIIMS is showing 1.75 SIL. So this was a toric planner for this particular case. You can see the pupil size is around 3 millimeters, and sometimes we judge the pupil rigid or a floppy. So this is a female patient, a rigid pupil. I thought I can manage this case without doing any subsequent requirement for extra manipulation inside the eye. So I'm trying to do a capsular access of around 3.54 millimeter size. And at this moment I realized, because this patient has a toric and not going to really give you a good access for a good emulsification and implantation. So this is how I do it. I make a 6 ports which are little posterior, that's how you can see the bleed. Keep all the hooks first inside the chamber, then one by one gently stretch them. Make sure don't catch the rhexis margin. For that you can put little bit of viscoelastic underneath. See how gently I'm making one by one manipulation. gives you a nice hexagonal appearance. So this is a trick here. If you have a hexagonal appearance, you're going to have a large, better space. And this wax is slightly smaller. I'm trying to further increase by painting the capsule with trypan blue dye, making an exercise around 4.5 millimeter. That will give you a good access for doing emulsification. The idea here is little posterior placement of iris hooks, so that don't tend the pupillary margin, won't damage the sphincter in those cases. Do some sort of hydrodissection. Normally, small pupil hydro procedure also very difficult here. Under the biscoat cover, we are doing a phacoemulsification here, because this is around grade 3, grade 4 nucleus, a little trench for a better hold in the middle, and trying to make a chop here. You can see this is the first chop I am trying to do, good initiation, but the rotation is not complete. In that situation, in all cases where you don't have a good hydrodissection, where nucleus cannot be rotated, you can take out a piece of nucleus here, do another chop here. So this gives you a space for an internal hydrodelineation, or in fact that completes the incomplete hydrodelineation earlier, and subsequent nucleus can be manipulated very, very nicely, and the surgery can be done effectively in these cases. So this is the end of surgery, inject a viscoelastic. Now actual plan is to put a toric lens, and how to manage this lens is the important part here. So I'm not removing the iris hooks. I'm making a little relaxing incision in the rhexis, which will prevent the future phimosis happening in a small pupil, and thus also decreases the chance of subsequent fibrosis causing decentration also in premium lenses. And this also gives a slightly enlargement of rhexis size also. So I'll remove the viscoelastic from behind and above of the IOL, keep the lens in the center now, then inject the viscoelastic, then take out all these hooks. If you remove the hooks before the, you place the lens inside in a proper position, then subsequently pupil constricting things become very, very difficult. So this is a trick in all those cases where you use a device for pupil expansion. You have to remove the viscoelastic from underneath, and before place the lens effectively, then inject the viscoelastic over the lens, and that can be taken away very easily also. So this is what this hexagonal appearance gives you, a nice spacing for emulsification, and also it gives you a nice size of making rhexis, good phaco, and remove the viscoelastic from underneath and over. That is mandatory for our toric lenses, so that they don't move. Subsequently, remove the hooks in these cases. So this is a case number 2, where you can see this patient also has come with grade 3 nucleus, female patient, had undergone radial keratotomy 25 years back. So which is a challenge all of us face, is a good calculation of biometry in these cases. This patient required a toric implantation. Doing eye trace, so look for actually corneal aberration. That is the most important part for all cases of refractive surgery. Make sure cornea is better. In fact, this patient had a very nice corneal aberration profile with HOA less than 0.4, good MTF and PSF in a corneal label. So this is the case here. The incision has to be little posterior. You can see at least 0.5 millimeter in sclera. That will maintain the incision integrity, because sometimes these incisions are almost 100% depth in the peripheral areas. And you can do a nice rhexis if you have access to image guided systems. Gives you a good access for a capsulotomy, and phaco can be done effectively in these cases. Normally, all these cases with myopia will have a little harder nucleus, despite having a good glow in these cases. They make sure you have a good coverage for endothelium. Compromised situation may be there in a post-refractive surgery, especially RK patients. Once you complete the phaco, you can aspirate the cortex and the epicortex in these cases. Make sure you maintain the integrity of capsular bag, which is very important for all premium lens implantation. Same holds true for our toric lenses also. So I'm aspirating the cortex now. Entire cortex has been aspirated, then injecting viscoelastic. The trick here is to implant the lens in a proper manner. Same thing here, as you saw in the previous case. Remove the viscoelastic effectively and place the lens in an area of concern. Maybe you put a suture in the main wound, because we have done a little posterior incision which will safeguard the incision, as well as should not be hydrating this area too much, otherwise the incision will spread out and open out. And once you have, even not opening, hydrated incision will have a post-op little fluctuation in astigmatism in these cases also. The post-RK, post-refractive surgery patient, we all understand we have to do a good IOL planning. Look for a feasibility of toric lenses. Sometimes if you have less than 4 incision, people put multifocal lenses also. But more important thing, look for cornea as such. If cornea is good, the patient is going to have a better vision. And Hagees and Barrett-Truquet may be a good formula nowadays for these patients. This part I've exactly explained to you during surgery. Suture may be required in these cases, especially if the incision opens up. There you have a little difficulty because each incision can be difficult to manage, so you may require a pursing suture sometimes also. These are difficult cases sometimes. If incision more than 12, you can have a post-op surprises in these cases, especially hyperopic shift, and sometimes they can have a fluctuation of vision also. The refractive surgery patient, good counseling is more important than surgery sometimes. Case number 3 is a patient who was again planned for phaco, and we knew that the patient had posterior polar cataract, anti-segment OCT, which we do routinely for a posterior polar cataract. We saw this pattern where posterior capsule was not clearly visible beyond the posterior disc of a posterior polar cataract. As per our classification, which Dr. Amar Pujari has published, it looked like a moth-eaten appearance, and this is the case here. Such cases have a high chance of a posterior capsule opening. You can say onion peel duplicated type of cataract. OCT picture is again, as you saw in anti-segment OCT. In IOCT also, it was a moth-eaten appearance. So we're doing a good capsular axis of size around 4.5 to 5 millimeter. Just a hydrodelineation. Just see this part now carefully. This hydrodelineation, you can see flutter in the middle here. I'll show it again. Just see this flutter. So this indicates there's an opening in the posterior capsule. So you have to be very, very careful there. Preserve the epinuclear mass. Don't rotate the nucleus. Do a chop here to take out the piece so that we create the internal hydrodelineation, as I showed in the first case. So this primarily we have taken out. The nucleus is just tucked in. We are not rotating the nucleus here at all. Now towards the end, I'll take out the epicortical cushion, which was quite thick. And you can see here at this time, you can see the posterior capsule already open here in the middle here. But we have maintained intraocular pressure by moderating the irrigation aspiration profile through the Centurion machine. Do a bimanual aspiration under the biscote cover that will maintain the anterior face of the vitreous. Still, this opening you can manage. I'll implant the lens inside the anterior chamber, open the lens over the iris surface, then stuck the haptic inside the rhexis margin. This will decrease the chance of enlarging the PC defect, because this is a defect which is large enough, I can't do the posterior capsular rhexis in this particular case. All posterior polar cataracts, normally anterior face doesn't get disrupted if you do a good phaco in these cases. So here we have learned that if you see this properly, you can decrease the chances of disaster happening in a posterior polar cataract. Must examine your patient carefully in the pre-op phase, do a good anti-segment OCT. If you have access to IOCT, that can give you analysis, what you have done. You can see here, you have done an endonuclear separation from epicortical cushion. So this tells you that you have a very nice separation here. And if you do a surgery which gives you access for a no rotation, then you can complete without damaging the posterior capsule and support the lens subsequently also. This is the type of cataract you all see. This is a young patient, had a white cataract, no leak of fluid. I thought it was an easy case. I thought I'll do a 5 millimeter rhexis. So this is what is happening here. The rhexis is not following my orders. So I'm injecting the biscote here to maintain the pressure. I thought I'll pull it out and reach nicely. I thought I'll enlarge further to make it a little larger incision. It has gone posteriorly here. So this hold was not appropriate. I was holding little away from the tearing edge. So I thought I'll go from other side to complete this rhexis, which normally we teach and we do like that also. So I could complete this rhexis, but it was not a complete circle. So there is an opening here, which is in the area where most manipulation might happen subsequently during phacoemulsification as such. The nucleus rotates very nicely under the biscote cover, as routinely I'll do phaco in this particular case. And pupil loss little floppy also in this particular case. I could manage the phacoemulsification effectively in this patient, but we all know that these cases have high chances of a tear extension posteriorly. So you have to be very, very careful in these cases, maintaining the pressure gradient effectively in these patients. I'm trying to aspirate. I could see the flap here. Entire PC extension has gone, tear has gone up to posterior part, right from S to S. So under the biscote cover, I'm doing a bimanual aspiration, which is the desired thing for these cases. Now you can see this is a tear all around, so we can't put the lens inside the bag in these cases. So this situation, we'll have to put a 3-piece lens and then keep the lens in a sulcus. If possible, you can capture the optics also. In this case, I had an extensional tear that I can do capture in this patient also. So such white cataracts, now in teaching what we do is, we need to see carefully in these patients' real-time examination and do anti-segment OCT to tell you which type of white cataract you are dealing with. So this is one such patient. You can see intumescence is evident. And OCT also gives you the convexity and the sheets, hydrated sheets, and all these pockets are inside the sheets. So these are cases where it's going to be difficult in decreasing the intralenticular pressure. The idea here is to see that you have to do imaging in this case appropriately to see what happens. So this is IOCT imaging during the surgery. First nick I'm doing here, nothing leaks out. So I'll do a little larger incision in the anterior capsule and make sure that I make around 1 millimeter opening so that it doesn't go to periphery. The tear extension normally happens if you cross the, the mid-periphery of lens. If you cross this area, the chances of extension is very, very high in such cases. So once you have this flap, now I can rotate to make it smaller. And always use high viscosity viscoelastic, which maintains the pressure. And if you do from a side port, the viscoelastic pressure is maintained throughout and less chances of the gradient happening in the anterior capsule from behind and anterior side. Because pressure from anterior and the pressure from behind has to be titrated well. At this stage, you can use the forceps to complete this rexus. Pull towards the middle here, towards the center, and this will tear off to a circle. Don't try to go this side. Idea here is to make a small opening. This is what I have achieved here now. You can see the entire mount, which is going to cause the pressure rise. Subsequently, aspiration with the IA system has to be done in such cases because entire cortex is hydrated. It's not a fluid here. And you can do a complete phaco in such cases after the decrease of pressure. And you can complete phaco and effectively implant the lens subsequently in these cases also. The white cataract imaging is necessity in these patients. The point to learn here is always examine your patient carefully. The anterior chamber depth, the bulge of anterior capsule, the convexity, the clefts in the subcapsular areas. See with the anti-segment OCT or IOCT what type of case you are dealing with. Subsequently, you can plan which are those cases where simple aspiration with help with the needle where you don't require to aspirate. If you have a type 2, which I saw a video, you have to aspirate with the IM cannulas in these patients, aspiration cannula. If you have type 3 cases where you have just a few fluid pockets are there, you can aspirate with the needle, you can do a micropuncture, you can do a laser punctures in these cases, you can come out with without difficulty. Type 4, where totally fluid is there you can have no problem in these cases. Let me take you to the other challenging case. This is a type hard cataract, which normally we see in the most of our practice cases, hypermature, old lady, 77-year-old, and you can see no fluid comes out. This is the case which is already gone beyond the raised intralenticular pressure. So I'm doing around 5 millimeter rexus in this particular case. And idea here is to bulk the nucleus or crack the nucleus without using phaco power in such cases. That gives you another dimension of managing hard cataracts to simplify the surgery and decrease the phaco power required. So this is my loop which is being used in these cases. And the entire loop should go underneath the capsule rexus margin. Then you have to rotate your hand in such a manner. It comes to the middle of a hard nucleus. Support this nucleus with a second hand. Then you can chop it. So this snare technique, which was ideally should have been some Indian name, but it's gone to Jais now with my loop. So this gives you another dimension. You can cut the nucleus in 2 halves. You can manipulate, you can make it 4 cuts also. Subsequent emulsification is safer. So these are devices which will be useful for future also in very, very hard cataracts. You can see I have a full crack in this case. Subsequently, I can take out the nucleus and decrease the amount of energy utilized in such cases of hard cataract. So all these innovations are going to help you in decreasing the complication happening in difficult scenarios. So this is a case I had completed with the significantly, almost 50% less energy was used in this patient, and I could subsequently implant toric lens in this particular case also. Here again, capsular rexus has to be significantly larger, that is around 5 millimeters so for hard cataracts. Hydrodissection should be complete, rotate your nucleus, inject some viscoelastic before putting the my loop in these cases, stabilize the nucleus with a second hand, then subsequently chop in these cases also. This is one of the last cases which I'm going to show you. This is a patient who had a trifocal toric lens in one eye, come for a second eye surgery, and I planned for a femtosecond laser with trifocal lens in this case. You can see I've already done a femtosecond laser. I could do a nice surgery in this patient. I thought it will be a simple surgery for this patient, and in fact it was very simply done. Entire emulsification was complete. I was trying to aspirate the cortex from all around. This is the hybrid technique of aspirating by manual aspiration. You can take out the cortex here. This is sometimes difficult to take out from the incision of aspiration port. So I'm leaving this cortex here, injecting viscoelastic. I was implanting the toric IOL in this particular case here. Now, next thing was to remove the viscoelastic from underneath and remove this cortical fiber. When I was removing this cortical fiber, entire capsule got torn from this side to this side. The half the capsule was open in this particular case. You can see the flap here now. What to do in this patient? You can't take out this lens, and luckily the interface is, vitreous face is intact. So I'm doing injection of dispersive viscoelastic underneath the IOL margin to support the anterior vitreous face. Idea here is to capture this lens anteriorly. So we're going to do a reverse anterior capture in this patient. I'll go behind and pull this optic up so that it supports above the rhexis margin, and this is the axis of implantation. My axis is already done. So this viscoat will not disrupt the vitreous face and give you space. Subsequently, I could, get captured. This is a bimanual technique. Both instruments has to be behind this and lift the optic up. Gives a nice capture. You can see the capture is done here. So this is a square shape. You can see very nice capture is done. So in such situation, sometimes this type of technique does help in these situations also. So this is a post-op picture, good outcome in such cases. So we have two scenarios. Sometimes this was the case you saw here. I had the lens inside, then capsule rupture. I could do anterior capture very nicely. But sometimes you have a situation the capsule is already ruptured before, but you have a rhexis intact and vitreous is not come. In such cases, open the lens over the iris surface, then tuck the haptic only, because optic is over the rhexis only. So this type of capturing is easier in such cases also. So I showed this some of few cases where you can make things challenging, but you can easily make simple for a management by doing a good examination, good imaging with anti-segment OCT, especially wide and posterior polar cataracts. If you have access to intra-op OCT, things become very simple because you know the dynamics of each surgical step during the surgery and assess what is happening, and detection of anything happening which is not as per your routine practice, then you can manage them appropriately. I think the success lies in seeing the thing and managing them appropriately to improve the outcome of your patients. Thank you for kind listening.
Thank you very much, Dr. Professor Tithyal, for presenting such an excellent and beautiful, wonderful, rare cases. Which recording system you use? So you have such a beautiful videos, like the crisp, clear, and such a beautiful glow and everything.
Luckily, we could acquire all these JAIS 700 with us, and we have the Callisto system which records high definition. These are not 4K pictures, because 4K everything is very difficult, it takes large space. Right. These are actual high definition recording directly from microscope to Callisto system, because we have all JAIS microscopes.
Right.
We don't use the external recorders as such.
Thank you. You're the second case of post-RK IOL implantation. So what was the post-op result like? You could find the neutral power or some overcorrection or undercorrection?
No, this particular case, I had a good result. I just hidden that particular slide. We had a good outcome because this patient had a very nice corneal profile. There was no fluctuation, and patient had a 6/6 vision post-op period and no fluctuation as such. But what Dr. Rajendra Prasad is asking is, there are some patients, especially if you have more than 12 incisions, and incision crosses the limbus, then you have a lot of fluctuation happening in your initial biometry recording. So sometimes if I do biometry in the morning, if I do in the evening, the records may be totally different. So these are difficult cases, and you have to really wait and see how these patients progress. If I can see them next 3 to 6 months, I realize what is the corneal profile, and accordingly manage these patients. So little myopic correction is desirable in most cases, so that you don't land up hyperopic in all myopic post-RK patients.
Especially because when you are going ahead with the toric lens, then it becomes more difficult. Because in any case, with the RK incision, RK cases, you tend to get the undercorrection actually most of the time, and then you have to add on to your IOL power. And but if it's a toric city, then it becomes more difficult to how to do.
Absolutely.
So thank you, Dr. Titial, for the excellent cases and beautiful presentation.
Thank you.
So
thank
we will.
you.
Dr. Balla.
So just one small question, sir.
Yes, yes.
That was excellent presentation in small pupil, post-RK, intumescent, hard cataract. I think you showed variety of all possible difficult cases. One small question, sir. In small pupil, where you had to put viscoelastic to put iris hooks, and later on you put trypan blue. Sometimes what we find is even after aspiration of the viscoelastic, the staining of capsule is very blotchy and it is not uniform. It becomes very difficult. But you could achieve very nice staining of the anterior capsule even after.
No,
So-
this could happen because we use, cohesive viscoelastic, that is 1% sodium hyaluronate, gives a nice space for a painting. In fact, Dr. Sudarshan had invented one painting cannula, where it had an opening towards the capsular side. You could paint the entire capsule underneath the viscoelastic. So you require a little space underneath the viscoelastic, then you can paint. It is very difficult under the methyl cellulose.
Even Professor Arshinov, he has invented tri-soft,
Soft
staining of the anterior capsule, because he inject viscoelastic first and then put the stain under the viscoelastic to stain the anterior capsule. And you get it, normally I do in most of my cases, put the viscoelastic first and then I stain the capsule. You generally get a very good staining of the capsule, and you don't get any problem. So thank you, sir. Thank you very much.
Thank you.
And
I think, can I make one announcement?
yeah.
Yes, sir.
I think we are going to shift to mini symposium after this, and we'll await the invited talk from Professor Dan Reistein from UK to us end, because he's going to join us from UK and going to talk about presbyopic correction.
So that will be the last, no?
Last.
Yes.
Yeah. So we'll close the case presentation now here and hand over to the mini symposium chairpersons. And we have chairpersons Professor Tetial, Professor Radhika Tandon, Professor Sudarshan Khokar, Professor Manavdeep Singh Bajaj, Professor Rajpal, Professor Namrata Sharma.
Professor Mandeep Bajaj.
And Professor Mandeep Bajaj. So they are all requested to come over on the dais and take over for the mini symposium. Thank you.
And the panelists are Dr. Nupur Gupta, Dr. Rohan Chawla, Dr. Rachna Meel, Dr. Praful Maharana, Dr. Manpreet Kaur, and Dr. Amar Pujari.
Thank you again, the DOS executive, especially Dr. Rajendra Prasad, President, and Dr. Ballaji for making this session so lively and effective. We are going to shift to a mini symposium that is on advanced technology in ophthalmic field. I'm going to take you through various areas of concern. The first area I'm going to talk about is, in refractive surgery. And Dr. Sudarshan Khokar would be talking on this, especially looking into a newer concept of a topo-guided LASIK, how it is done and how effective this. We have various instrumentation where topo-guided LASIK can be done. And he'll talk about the topo-guided LASIK in thorough so that we realize what is best for our patients. Professor Sudarshan Khokar, please.
Thank you, Professor Titial, and members on the dais and off the dais. Well, how many people have got access to the refractive surgery? Can I just see a raise of hands? Perfect. So about 50%. And how many actually have a EX500 machine or a Contura machine? Some people want to call it Contura. It's an Alcon machine called EX500. There are other machines also which can do the same job. I think all these machines are good for myopic surgeries, and they have a specific protocol of doing a wavefront guided, wavefront optimized, or a topo guided surgeries. So this platform, when they started, was given to all the machines across the globe, but certain machines, because of their hold of the the media and things, have come out into the play, whereas the other machine can deliver equally well. So I'll be discussing here a topo-guided ablation. So what is ablation? Ablation basically depends on a simple equation given by a Mundell's equation, which says that the more the more the diameter you take, the deeper you cut. So that means in good old days, people used to take out -10, -12 from the surface with PRKs. They were taking smaller zones. So smaller zone means you lose less tissue and get more deeper effect. But you had a problem because the pupil size will come into play, and there will be the edge effect and the glares and rainbow glares and all those funny things, so people have given up. So the ablation size has become bigger. So if you're doing ablation which is bigger, you're actually taking more tissue off the eye. Just keep that in your mind. That is all dependent on the Mulron's equation. So okay, here we go. So for the residents, basically, this is what is the basic of all the ablations. So ablation is you're removing the tissue out of the cornea. You take off a flap. It's like your car has gone for a repair. You open the bonnet, repair it, and put the bonnet back. So you take the flap up so that your post-op recovery is faster. There's less pain in this patient, better wow effect as compared to PRK patients. Then you repair it, you do the ablation. So ablation is what you remove the tissue to mold the cornea. So you can do a wavefront optimize. The problem here is that you actually do not correct the pre-existing higher order aberrations. All these platforms are good for the lower order aberrations, meaning a sphere and a cylinder. So even if you can do a refraction, a sphere and a cylinder, put in the data and cut the cornea, 90% chances you won't have a problem. So you don't need to have all the high-end machines. Once you get the corneas which are abnormal corneas, in which the RMS has gone a little higher, those are the machines that you want to have a better specific cutting. So when you go to the wavefront guided, it corrects the pre-existing HOAs also. So you can pick up the higher order aberrations and you can cut them also. So you need to have machines which can take the cylinder spheres and the higher order aberrations and the topography. And the last one is the topography, which topo-guided, which is what I'm going to be talking about. Okay, so Alcon calls it Contura. Carl Zeiss calls this Tosca, which actually is the same thing. J&J has an eye design and Nidec has an OPD cat. So this is what you're actually taking the contour and trying to address the contours. That means you cut actually more from the periphery rather than the central, so you lose more tissue in these ones. So topo-guided indication when it started was basically for the irregular corneas or retouch-ups or the fluctuating refractions. But there are certain studies which have come up in which they use on the virgin corneas also. The studies on using EX500 as well as MEL90. And with that in mind, we picked up a study in which we compared both the machines, the EX500 and the MEL90, to find out which is better and which one should use. So what happens when you capture the image? The problem is in the Alcon system, the capture the image is not very simple because the machine decides how you take it, and you have to have all the images similar to each other. If there's an error, it will reject it. So you can't take more than 40%, about 60% of patient you can actually capture the data. In 40% you just can't do it, whether you claim it or not, but you can't pick it up. Whereas on the other hand, if you do the same thing on the Atlas machine, where you have to see that the 7th and the 8th and 9th circles should have a similar distance in between. If you can manage that one, which you can actually do it between a 99 to 100% of patients. So this is what it looks like. And so you can pick up these images and do it. Of course, these kind of images which are not clean should not be taken up on both the sides. So this is what is Allegro, in which you actually can't take the images in all the patients. So Allegro gives you, Alcon gives you about a 5.5 central zone, whereas the MEL90 actually picks up your 6 millimeter zone. So this is a study in which we compared a group, both the groups, 160i of patients, both the groups. Everything was fine. This one, the pre-op data matched, the post-op data matched, the pentacams and everything was good in these patients. Even the so the only thing which we found out that if you look at the higher order aberration, we found that the higher order aberrations were much better with the MEL90 as compared to a EX500, and the spherical aberration in post-op also was little to the positive side as compared to the MEL. But this was a small size, so maybe it might differ. So anybody who wants to discuss this can talk to me later on because my time is running. And this is a surgical procedure which I think is simple. I mean, anybody who uses a machine is same, so it doesn't make much difference. The only thing is when you're doing a topo-guided, you're actually cutting more tissue from periphery to inwards. So you might have to use a bigger PIs to have a bigger flap size. So just to cover up this one, if you're capturing the image, it's much simpler to capture the image in a MEL90 protocol versus the EX500, which is a Contura vision. You pick up a 4 scan which is faster, and if the 3 scans are good, any of these good scans, and if your refraction is good, you can actually go ahead and do these surgeries without much problem. So we did these surgeries and we realized till 6 months, both the surgeries actually fared equally well. In fact, we have better higher order aberrations in MEL90 machine. So there was no objective criteria. That's the only problem. There's no objective criteria. The machine doesn't decide that you can operate or not. You decide yourself in this patient. Of course, you have to take into the consideration the higher aberration, the refraction and everything, and then you can come to this. Planning is simpler, no complication, and the only problem with the EX500 for the MEL 90 is that it runs at 250 hertz, so it takes double the time. If other machine takes 10 seconds, this will take 20 seconds. So you have to keep talking to the patient constantly so that he keep looking at the central fixing light. If you can achieve that, both the machines work equally well. So even if a patient comes for Contura and you have a machine, say MEL 80 or MEL 90, or even an older version or a J&J machine, you can still deliver a topo-guided surgical protocol, which Contura is just an Alcon name for that topo-guided procedure, and otherwise the other machines can also do it equally well. Thank you very much.
Dr. Khokar, wonderful presentation. I think you can take the chair. In the meantime, Radhika can fix up the presentation. Just one query, Sudarshan, you compared two devices and outcomes are almost similar in both the categories. What about comparing Contura versus no Contura or no topo-guided treatment? How the results will be actually different?
Actually, if you're doing a wavefront optimized, which I think 90%, 99% people are doing, even in the Contura claimed people, they can't do Contura, and also even 50% they are also optimized only. So it works well. I mean, till the patient knows, and if only thing is you have taken the data properly, your refractions and things are good, and you've taken a topography well, and you've taken a higher aberrations, you can't go wrong. So saying that a topo-guided is superior to other one, it is not correct, because majority, and it's much easier to do the wavefront, and it's the less chance of causing harm or wrong in these patients, because if the topography data is not taken properly, you can actually cause more problem to these patients. This I wanted to show that it's not only one machine which has a topo-guided called Contura, the other machine can also have it. To do that one or not is what your discretion is, but I suggest that all the people should actually know how to handle a wavefront optimized ablation. I think that's what you wanted to know.
Thank you, Sudarshan, for clarifying. Now we have Professor Radhika Tandon. She's going to talk about the something new, bioengineering corneal practice, because many things are coming up, and future direction is on to that something we develop, as bioengineered cornea. Dr.
Thank
Radhika,
you so
please.
much, sir. Good afternoon, everybody. I'm going to give you a little insight into some of the experience that we've done at our center in this field. Biomedical engineering is an application of the principles and problem-solving techniques of engineering to biology and medicine. And in ophthalmology, the scope is limitless, but I've just selected three areas. One is the role of artificial intelligence to help with diagnosis and analysis. We look at tissue engineering and also recovery. There is also the scope of expansion, 3D printing, and gene therapy. These are broadly the areas where ophthalmology can benefit from these principles. Now, exploring AI-based solutions for developmental abnormalities of the cornea, I'm giving you a small insight into a little bit of work that we've done. There are several developmental abnormalities of the cornea. A few of them are a little difficult to differentiate straight off, and also in peripheral areas, people may have challenges in deciding. So we have isolated three areas of interest: primary congenital glaucoma, Peters anomaly, and corneal dystrophies, CHED. You might wonder that why primary congenital glaucoma? We all know they have a large cornea, and what's the big deal in diagnosing? But it can sometimes be confusing, particularly if patients present late. So you require a multidisciplinary approach, and also there is a scope later for geneticists and engineers. Looking at the entire spectrum of anterior segment imaging available to us, combined with the clinician's input, the history of the patient, the profile of the patient, as well as histopathology. So I'll share some of the work done by Dr. Ananya Kaginalkar as part of her thesis, and I'd like to acknowledge the contributions we also had from the Dr. Dinesh Gupta from ICGEB New Delhi. Now, looking here at the results of a spectrum of patients, there were 42, there were 82 eyes which were included for analysis, and generally you will find that even the clinical profile there are variations. So for example, with primary congenital glaucoma, they presented more early, whereas in CHED they presented much later compared to the other two. Looking at the demographic data again, there was a significantly later presentation of CHED as opposed to the other two groups. And this is all the inputs that we put it into the artificial intelligence system so that we can have a sort of a simplified approach to the diagnosis. So apart from the clinical parameters, we also put in the various clinical images that we had, and there was an internal testing data set which was first created, which showed an accuracy of 95.65% to begin with, and then we had the uncertain cases which were then input, and then that was the external testing database, for which the accuracy was 77.78%, which is reasonably acceptable. Anything more than 70% is considered in this circle as a good result. Looking at the diagnostic accuracy, therefore, the clinical picture, internal as well as external, and we had a good correlation for all the disorders. And as you can see, there's a difference. So CHED was a little bit lower, primary congenital glaucoma was a little bit higher, and so on. And then we look at the input for each image that we had. So IOCT had an extremely high accuracy. We also looked at UBM. And the IOCT images were particularly helpful, and the UBM images as well, giving very high accuracy for correlating with the external images that we put in. And the diagnostic accuracy with the UBM images, as you can see, was 100% across the groups. So a summary of the AI results, this is just a small exploratory model that we started with, and we found that the results are very encouraging, and more work is ongoing. But here I would encourage everybody, whatever information is available, capture it. Even a simple photograph can be very useful, and of course follow-up and visual rehabilitation data also has a role. Now coming to tissue engineering, a few applications. You all know that culturing of limbal stem cells has been going on in our country and across the world for a long time, and there's a lot to be learned from this field. Given the importance of being up to date, we also looked at how we can adapt the technology in our scenario for culturing limbal epithelial cells, and we were able to demonstrate that by using locally adaptive methods, we were able to generate the same quality of cells as generated abroad. And then on practical clinical applications as well, there's a proof of concept clinical trial, DCGI approved, for culturing limbal stem cells, where you have a confluent sheet to confirm that the cells are healthy, you confirm that they have all the characteristics that they're supposed to have as we found in the natural body. So the journey from bench to bedside, then as you had greater confidence, there were more surgeons who were willing to accept the technique, and we looked at long-term outcomes. Patients who had these reconstructive techniques done, they later went on to have DALC, and then the histopathology of the buttons also confirmed that the cells were of good morphology. Then looking at a systematic review for patients who require limbal stem cell transplant. So we all know that there are a whole lot of varieties of techniques that are available. What are the outcomes of surgical interventions for the treatment of limbal stem cell deficiency? Unfortunately, there's an inadequacy of RCTs, and a lot of the publications are small case series. But looking at the available information, the few studies which had comparative data, as far as the anatomical success rates go, SLET is the highest. So here, good news for everybody who is now taken over, switched over to SLET. CLET also had good anatomical success, and also the previous procedures which were used, such as the direct conjunctival limbal allograft or keratolimbal allograft, they also had good anatomical success rates. The only problem with KLAL is that you would require severe, very heavy immunosuppression because it was an allograft. And as far as functional success rates, as a gain in visual acuity, it was better with SLET as compared to the other two. But remember that there are no RCTs, so there was no standard patient selection, etc. So there are several reasons why there could be differences between the two. And of course, fibrin glue has made a lot of difference. With fibrin glue, the technique is so much simpler. So SLET is a good technique, but at the same time, even direct limbal lenticule application has become so much easier with the presence of fibrin glue, and autologous limbal stem cell transplant with CLET also, you can see, can have good results from both the donor site healing up completely as well as the recipient eye. So if you have a unilateral autologous limbal stem cell transplant, we have an RCT in progress to see whether a direct limbal lenticule, SLET or CLET, which of them would actually be practically better. And generally, one would find that the process is under analysis, but in practical terms, if you have a patient of limbal stem cell deficiency, you're going ahead for a SLED procedure, that is completely fine and acceptable. Coming quickly to the concept of expansion of corneas, we know corneal blindness is a big problem in India. The prevalence has been demonstrated to be very high, and the supply does not match up to the demand. So donor tissues are required. There's one thing I'd like to share, that we have looked at the long-term preservation of donor corneas in glycerol for keratoplasty, exploring new protocols, and it's definitely helpful to keep the corneas at -80. The tissue retains its tensile strength and has a little better transparency, and you can keep it for long, even 1 to 2 years, and these tissues can come in handy later on, as was proved during the COVID pandemic. Looking at other substrates for amniotic membrane, we have biological substrates, we have synthetic substrates. The benefit of a synthetic substrate is in remote areas, it can be available for emergency use. It can also be autoclaved. So that is a benefit over a fresh amniotic membrane or stored or preserved amniotic membrane. Looking at the benefits of which substrate to choose, we selected polycaprolactone. It has good physical properties, which has been confirmed by testing from IIT Delhi. And we did first our in vitro experiments. Surface modified electrospun scaffold we found was the best technique. It had a reasonable transparency compared to natural amniotic membrane, and it had a good bioactivity for damaged ocular surface reconstruction, which we then proved in the lab by growing limbal epithelial cells over the scaffold, and showed that the cellular response of the cultured tissue was identical to what you would get with human amniotic membrane. So now we said, we're in a position to move to the to clinical application. We first started with an animal experiment. This was in rabbits. Dr. Raghav Ravani did this as part of his thesis. We did an experimental evaluation in rabbit eyes and found that the epithelial defect healed. There was no significant difference between the membrane and human amniotic membrane, and the characteristics of the cells were also identical. And finally, tissue engineered constructs. We can look at various models of electrospun scaffold to have better tissue proliferation. And I just wanted to show that again with IIT Delhi, we have used cell sheet engineering so that you have a faster proliferation of the cells and easier cell detachment. And finally, we have looked at decellularized cornea, what Dr. Tityal was talking about, that we have the many donor tissues which are discarded by many eye banks, and we would like to take this tissue, decellularize them, and operate. Here again, this is the animal experiment using decellularized corneas. This is when a pocket is created, the cornea is implanted, and this is 2 months post-op. You can see very nicely integrated and completely transparent. And this is the surgery in animals. I'd like to show, this is being operated by me with the help of the neurosurgical lab. They have a very good experimental lab assisted by Dr. Raghav and other senior residents. So I'll just go forward. You create a pocket, a lamellar pocket, and then the decellularized cornea is inserted into that pocket. And a suture is placed. And this is the tissue immediately on the table, but post-operatively it becomes absolutely clear. So hopefully we will be able to provide this kind of bioengineered cornea for stromal reconstruction in the future. Thank you very much.
Okay. Thank you, Professor Radhika. That was a wonderful presentation. So maybe you can discuss with her later about the intricacies of this, because we are running a little behind schedule. So the next speaker is Professor Namrata Sharma. She'll be talking on corneal angiogenesis. Professor Namrata, please.
Thank you, sir. I would be Okay. I'll be talking to you about corneal angiogenesis in the next few minutes, a topic which we understand less about, and what is the future and how you are going to deal with it. So important thing is that in all the things that I'm going to mention, but there's no financial or proprietary interest. Now, if you look at the corneal angiogenesis, basically cornea has a avascular privilege, but it is disturbed by hypoxia, injury, or inflammation, which triggers the endothelial cells. And so it leads to a cascade of pro-angiogenic factors or anti-angiogenic factors. And whenever you have corneal vascularization, there's only one factor which is common, and that is inflammation. Now, this can occur in variety of conditions, such as dry eye, or you can have vascularization and herpetic scars, even in chronic cases of pseudophakic bullous keratopathy, or in cases of limbal stem cell deficiency, even in cases of infections related to the suture or related to the graft-host junction, or in cases of failed grafts, and even in cases of intacts such as this, along with lipid keratopathy. And these are the cases of resolved keratitis where vessels are there on the cornea. So it is a play between these pro-angiogenic and anti-angiogenic factors which we have to target in order to get rid of vascularization. Now, why should we manage corneal vascularization? It is important because it will lead to fibrosis, scarring, lipid keratopathy, so that will lead to loss of best corrected visual acuity. And also, if you try to do grafts in these cases, then there's chance that the graft will fail and there'll also be graft rejection. So there are various management options. The anti-inflammatory agents such as steroids, VEGF pathway inhibitors, MMP9 inhibitors such as doxycycline, dipyridamole, and mice. Then physical ablation methods such as fine needle diathermy of vessels, argon laser, PDT, and again mice. Then there are various gene therapy, various forms of gene therapy which have been tried. And this is the one that I added because I feel that even the ocular surface procedures that you do like amniotic membrane or clet, or slit or COMAT, even these inhibit the angiogenesis on the cornea. Now, as far as the steroids are concerned, they inhibit the neovascularization and they are supposed to be most efficacious when started immediately after tissue injury. And the main role is there in limiting inflammation, but they have limited angioregressive capacity and they're not useful once neovascularization is established. Now, there are inhibitors of VEGF pathway and we are all aware of these drugs like Avastin, Lucentis, etc. This can be given topically, subconjunctivally or intrastromally or sometimes in combination. They are useful in regression of superficial and early vessels, but they have less effect on stable long-standing vessels and possibly no effect on deep vessels. And if the insight, that is the inflammation, is uncontrolled, this can also recur. Now, this is just to show what are the routes which we would take depending upon the vessels. So if there are focal, deep and peripheral vessels, then these anti-VEGFs can be used subconjunctivally. If there are focal, central and deep vessels, then intrastromally. And if there are diffuse, superficial and central vessels, then one can use topical anti-VEGFs or combination of these. Now, this is one of the first studies which did show that Avastin does better than Lucentis when given intrastromally and subconjunctivally as far as the vascularization is concerned. However, there was this contradictory study again which said that cases which are refractory to Avastin responded better to Lucentis. And this was another study which compared Lucentis and Avastin and said that Lucentis is better in terms of onset of action and degree of efficacy topically, but there are no prospective randomized head-to-head comparison which is required in these cases. Now, if you compare the two molecules, Avastin is got larger, it is larger size and it also has greater systemic effects as compared to Lucentis, but the corneal penetration of Lucentis is better than Avastin. Now, this is a study in 50 eyes of high-risk graft and which showed that the graft survival increases from 40 to 70% and it also decreases neovascularization when subconjunctival and topical both Avastin was given. This is our study where we've been trying to use subconjunctival Avastin in corneal neovascularization, especially cases of resolving microbial keratitis. And we found that there was reduction, 30% reduction in the area of neovascularization at 3 months follow-up, and this was presented in the American Academy of Ophthalmology. Some of the cases, of course, you have to be very selective about the cases. If you take chronic cases such as this, it may not give that much amount of effect. But if you take cases which are just resolving, then not only it will decrease vascularization, but also will help in clearing of the cornea. And this is yet another case where intacs was present with lipid keratopathy. This was removed, followed by subcorneal Avastin because the feeder vessel is here. And again, in this case, the vascularization has decreased. Now, this is something that we have started, and this is the angiography which is being done for corneal neovascularization. And look at the vessels. You can see the vessels, they are showing fluorescence, and the vascularization which is there in the cornea is also showing fluorescence. This we are doing in collaboration with our retina counterparts, Dr. Shaurya and Dr. Saurabh Verma are helping us in this. So this is how the vascularization would look like. And in this case, we gave 2 Lucentis injections, and this is at the first follow-up visit after the first injection, and this is after the second injection. So you can see that the vessels are decreasing, and also the cornea is getting better as compared to the time when you see them preoperatively. Apart from these anti-VEGFs, there is role of doxycycline, but this has only been used in vivo. Dipyridamole, again, there are only 2 studies which have used these drops in cases of pterygium, and 1 from our center by Dr. Vel Pandian group. And this is described by Dr. Dua, that is the fine needle diathermy for single thick vessel. Along the vessel, you actually take this 10-0 monofilament nylon suture, cut it short, and just pass this needle so that you go into the lumen of the needle without going into the stroma, and then touch diathermy. So as you touch diathermy, there will be blenching. And you can see cattle tracking as the vessels regress in these cases. Now this is just to show a case of corneal neovascularization again, where fluorescein angiography has been done preoperatively. And here we have done this fine needle diathermy, where the needle is taken and it is inserted into the lumen of this feeder vessel that is there, and you just touch this with the diathermy. So as you touch, there will be blanching will be there, and you know that it is that vessel is blocked. And then this, because there are peripheral small vessels here, so this is along the limbus which is being done. And again, the end point you will note is blenching that happens in these cases. Once you remove the feeder, it will get clear over a period of time. Now this is another case, and this is what is MICE, which is a new technique, mitomycin C intravascular chemoembolization. So this is an adherent leukoma, and again fluorescein angiography has been done in this case. You can see the vessels which are there all over the cornea, and this is a chronic scar. And again in this case, the mitomycin C is being injected into the lumen, and as you inject into the lumen with a hydrostatic pressure, the mitomycin C goes and lines the endothelium, and then one can see that the blood in that vessel will get obliterated. There might be some cattle tracking which will be there, but this obliterates in the post-operative period. Now, for a case like this, clarity is not what we are looking at, but if you do have to do a graft, you don't want it to reject or to fail, and that is why this chemoembolization is useful. The only genetic modality which has been found to be useful, there is only one study which is there, and the molecule is aganiricin, which is the only gene therapy in phase 3 clinical trials, in which already 69 subjects have been recruited, and these are cases with keratitis. Like I said, I do believe that when you do amniotic membrane transplantation, it does have anti-angiogenic effect, and this was our randomized control trial where we clearly showed that the vascularization is less. So where AMT was used, look at the eyes, which look so white, and where AMT was not used, amniotic membrane was not used, they look inflamed. So amniotic membrane does have anti-angiogenic properties. SLET and CLET, we've just concluded a randomized control study where we did show that SLET has less vascularization as compared to CLET, and also has better visual acuity as compared to CLET. And this is going to be published soon. And this is just to show that if you just do SLET, the cornea is clear, and this is 12 years down the follow-up. Now COMET, again, when you take oral mucosa, and this was the PhD work of Dr. Renu Venugopal in chronic Steven-Johnson case, these are the pre-op pictures, and these are the post-op pictures. So you can see that the vascularization this side is much less as compared to this when you do COMET in these cases. And we did look at the MMP9 expression which is there in the pannus, and we found that the corneal vascularization was correlated by the high MMP9 which was present in these cases. So where do we stand as far as corneal neovascularization is concerned? It is an inherent part of many inflammatory disorders. It is important to treat the inflammation at the earliest to prevent angiogenesis, and that can be done with steroids. Early angiogenesis may be addressed by anti-VEGFs, although a lot of work is required in this. Established angiogenesis, you can combine one or two techniques like fine needle diathermy or mice, as I showed you. And AMT, SLET, COMET, and even mucous membrane graft may induce anti-angiogenesis. And of course, gene targets hold promise in future of management of these, this corneal angiogenesis. I would like to acknowledge Dr. Priyadarshini, Dr. Amog, and our retina people, Dr. Shaurya, who's sitting here only, and Dr. Saurabh Verma for helping with this project. Thank you very much for your kind attention.
Thank you, Dr. Namrata. Now I invite Professor Pradeep Venkatesh. He will be talking about artificial intelligence in vitreoretinal disease.
No questions for Dr. Namrata?
No, fortunately, Pradeep.
Yeah, essentially, I mean, I enjoy my work as a clinician, but during the COVID time, I had a lot of time on hand. So there's a Stanford course that's given for artificial intelligence in healthcare. So I happened to complete the 4 modules and have been certified for that particular course. Subsequently, I had an opportunity to be a co-investigator. The study was led by Dr. Nikhil Tandon at the Department of Endocrinology. And ARDA is the Google Verily AI software that actually tries to detect and classify diabetic retinopathy. And here we're just trying to see its role in young diabetics. And again, during COVID time, I tried to do a few experiments with available semi-AI tools, and then a few publications I'll subsequently share. Now, AI, Dr. Radhika ma'am did mention about a few things on AI, but there's some fundamental questions that you really need to ask, and this is what I'd like to cover during my presentation. Now, is this actually intelligence? Now, if you look at the figure over here, the figure down, you're seeing one image carrying an animal or a bird, and the next a landscape that's there. Now, this particular algorithm was created by a well-known AI specialist, and the purpose was to classify if the image has an animal or does not have an animal. It performed very well in the test conditions, but subsequently he realized that when very sharp images of an animal were being given, it said that there is no animal, even a child could have picked up that there was an animal on that image. So he was perplexed at what was happening, and so he went in deeper to see what actually the machine was learning. And if you see the bird image, the background is blurred. The focus is on the bird itself. So what the machine had actually learned was when the background is blurred, there is an animal, and when everything is in sharp focus, there is no animal. So it was actually not seeing the animal itself or the bird itself. So this is not intelligence. Now these are the other blunders that the AI is known, and these images were all taken by award-winning and best-of-class image algorithms. Okay, in the first set, I think it's very clearly evident what the AI caption did. The Microsoft and the Google have some captioning software, which is largely AI-driven, and you see the first image saying that the dog is jumping to catch a frisbee, and there are other silly answers over there. But more importantly, when you look at this particular image, all the left-sided images, it classified correctly. But when the subsequent images, now the right-side images, where actually the pixels were changed a little bit in the right side of each of these images, and almost all of these right images, the AI algorithm categorized as an ostrich. Okay, and nobody knows why. Now again, this is not intelligence. If you see these pixelated images, I mean, none of us can actually see an image, but 99% of the times, one of the best algorithms ever created, categorize these pixelated images as whatever you're seeing over there. And again, gross misinterpretation can happen even with minor changes. What are the successes? When you talk about successes, we'll have to look at the general successes because the application to medical field came much later. So initially, there was a lot of noise about it beating Garry Kasparov in chess, and then subsequently the AlphaGo was supposed to be more difficult to beat, and ultimately that too was achieved. And then your Siri and Alexa are all based on AI itself. Now Tesla, the driverless vehicles, again, are AI-based. But if you go back to BMW has given up its attempt to create driverless cars, and obviously there's a problem over there. I mean, look at the medical success. Mycin was created by Stanford, but very soon it couldn't be really applied into clinical situations. Now the IBM Watson is an important story. Now this particular software or algorithm was created in 2011. It was touted as one of the best. It beat the world champions in a game of Jeopardy, which is essentially a question and answer kind of a game. And then subsequently it said it could be made into a personal medical assistant. And they said that within a week, they fed almost the entire medical literature into Watson. And then subsequently, in the subsequent week, 25 million publications were fed into this. And then they started marketing it. And the Anderson Cancer Institute and other places acquired this particular algorithm. It was sold to multiple clients. But now fast forward to 2019, and almost all those contracts have been cancelled, and it's been accused of over-promising and under-delivering, and now this is an AI parlay. Okay, now it's a contender for the most notorious hype award. This is as recent as 2019. So how does AI actually function? So essentially, you're given an input, and then it has a massive data set of images, text, pronunciation. So it just extracts the closest answer that's there to the input, and then it generates an output. Essentially, it's a data extraction and delivery tool. There's very minimal intelligence that's involved over there. There's several phases in AI evolution, the most recent being the deep neural networks. The earlier networks had only one interface, which was actually creating the analysis, but the deep neural networks have multiple layers of analysis, and so they're supposed to be more powerful. Now, like I said, there are many ways of training an AI algorithm. The precision essentially depends on how you've created the testing cycle, the validation cycle, and the training cycle. So it essentially depends on that. There's one important thing to remember, that AI cannot multitask. If you've created an AI to play a game of chess, it cannot play a game of checkers. So it's master of only one task, and that's again important to understand. Now coming back to the basic topic of why AI in vitreoretinal diseases, essentially it's been that we've not been able to achieve screening targets in diabetic retinopathy. Even in the US, only around 50 or 55% of them, or max 60% of them actually proceed with all the guidelines that's recommended. So a lot of factors related. It's important to question ourselves, can AI replace all the patient-related factors, disease-related factors, health-related factors? There's a lot of impetus to say AI because we're generating a lot of data, particularly after OCT is come in. But what is the reality? Like I said, the input sources, color images have always been there. Now you have the fundus autofluorescence images and the OCT images, and there's several patterns that it recognizes, like we write on our clinical notes. Now, more recently, in 2019, until now, all the medical devices that were sanctioned by FDA were static. There were no dynamic changes occurring, but with software, you see dynamic changes occurring. There's change in algorithm, and every time there's a change in algorithm, they need to recertify it. So they've come up with a new category of guidelines on how software can actually be certified as a medical device. And many conditions that have been assessed with this, essentially diabetic retinopathy, AMD, ROP, are predominant diseases that have been checked, and there are many things that you can actually do: measure the CNV-associated changes, measure geographic atrophy changes, and assess drusen change. In diabetic retinopathy, you need to orient the images very well, and then you can again follow up just like in your simple OCT. But more recently, they've said you can take the hot maps provided by the AI, you can overlay it on a fundus image and treat only those areas which are showing a hot spot or a hot area. This particular software or an algorithm was approved very, very recently, and it actually had around 8 lakh images of 1 lakh patients. And then they said that it can screen almost 2,500 images in 1 hour, while humans can do only around 10 to 12 images per hour. But the important question to ask is, do we really need this kind of a speed, 2,500 images per hour? What does it actually translate to? So does it mean that patients who are having independent setups where the patient load is not very high, the AI is useful because they're not going to have such a big load to analyze so many images? Does it mean that AI needs to be centralized, meaning that only major facilities have this, and all the images taken by others are directed to the central facility? Now you're actually screening so many patients, but what about the management and the treatment rates? Can it catch up with your diagnosis rates? Again, these questions remain unanswered. And when you invest so much on the infrastructure, manpower, and the proprietary software, what is the returns? There's no clear answer on this. There's a lot of hype. Now, there's some simpler solutions that I've been thinking about for the last few years. So one was the basic problem in diabetic retinopathy screening is accessibility. And so you actually have to work on a device that the patients can themselves use. So one of the initial tests that we did around four patients where we had the Bosch handle fundus camera, and we realized that they needed little coaxing, and then we needed to train them before, so they could take their own fundus images. And subsequently, we did a study, and then it was found that majority of patients could actually capture their own fundus image. But the second study we did had a in-view camera. Now, this particular camera costs only around $1 lakh. And it autofocuses, and the moment it autofocuses, it takes 9 images on its own, and you can actually see this one patient, and you can see the fundus image, his own fundus image, very clearly on the smartphone screen. What about Google Lens? Now, Google Lens came about in 2017, 2018, and it can, you put a photograph of a flower or an insect, and it immediately tells you what insect it is, the rarest of insects. So that's when I wanted to actually assess that it is a semi-AI based tool. Can Google Lens itself be used as a readily available AI tool? And I tried to take the Mesidor dataset. Now the Mesidor dataset is a European dataset of fundus images. I took permission from them, downloaded the images because they were standard images. I then uploaded them onto Google Photo, and then I used the option of searching using the Google Lens. I was surprised to see the replies or the outputs that I got somewhere as vague as a colony of microorganisms, and then on a culture plate, and then some of them said it was AMD. Obviously, the problem was not with the Google Lens. The problem was there were no, data sets like we have with most other images, like the flowers or the insects, that were readily available for the Google Lens to search and provide you with an appropriate answer. So what you actually need to do is to have a large image data set that's out there, allow Google Lens to access those images, and then provide you with actual classification. Once you have this, a selfie fundus camera, a Google Lens based, okay, sorry. Yeah, I think I'll stop. Yeah, thank you.
Sorry. Thank you, Pradeep. I think we'll have discussion subsequently, because this is a subject which requires a lot of discussion for future also. Thank you for making this presentation. In fact, we are joined live from UK, Dr. Dan Reinstein, and we'll have his talk first before we finish other talks also. We know that, hi Dan, welcome to India, New Delhi. And this is a meeting, Dan, regarding the Delhi Ophthalmological Society, which is the largest state society in this country, more than 10,000 members. And today we are fortunate that you accepted our invitation to talk about presbyopic surgical correction. You all know Dan Reinstein is a pioneer in refractive surgery world over, and he has so many publications, teaching, clinical experience in various refractive surgeries, and we all follow his norms, regulations, and today it will be a pleasure to listen to him. Dan, all yours. You can present your talk today.
Thank you. Actually, I was really enjoying listening to Akesh's talk. I'm Sorry you cut him off. Right, let me share my screen for you here. It's a beautiful, fresh morning here in London. Okay, is that visible? Properly visible?
It's visible. It's visible. Yes.
Excellent. Whereas the German state, visible. Okay, so you've asked me to speak about the surgical management of presbyopia. And obviously, many of you know that I developed a procedure called Presbyon many years ago, which is now commercialized by Carl Zeiss, so I have a financial interest in that. My other financial interests, which are to do with epithelial mapping and diagnostics, are not really relevant to this talk. So, the eternal discussion, the argument is that you should correct it on the cornea or you should correct it on the lens, and this debate, they're almost like two separate planets of people not really able to communicate, and this debate has been going on for 20 years. And it's funny to me because I've actually looked at it another way. I've thought that this is not about two completely separate planets at all. It's actually about three planets. And the three planets are multifocal optics, using spherical aberration to increase depth of field, and monovision. Those are the three planets. And it's just a reclassification of the argument. Everyone has been aware of multifocal IOLs and multifocal corneas with little inlays and multifocal corneas by ablation. Everyone's been aware of contact lens monovision, IOL monovision, obviously LASIK monovision. What I think is the area that people are less aware of is extended depth of field using spherical aberration. And the first real procedure to do this was what I called laser blended vision in 2004 when we started developing it. And this is not monovision, this is actually a modification of binocular vision. And stereo acuity is maintained and binocularity is maintained. So it is in the middle of these two. And of course, we now know that there are a number of IOLs in the world, whatever, 15 years later, that are coming onto the market that are based on these principles of modifying depth of field using spherical aberration. So, just briefly, let's go over multifocality. And I don't have to belabor this because this has been the topic of 60–70% of the airtime at all of the big meetings. Damien Gatinel published a beautiful paper showing the different kinds of lens that have bifocality or trifocality or EDOF. And here's what was called an EDOF lens in 2014. It came out at the London ESCRS, the Symphony, the company was saying that this is not a multifocal lens, it's an EDOF lens. And when you put this lens through a Osiris, which has an extraordinary resolution, there you find that, of course, it's a diffractive IOL, and it does cause night vision disturbances, and it does cause the same effects as other multifocals, reducing contrast. So there's no free lunch on splitting light. On the cornea, we have a very beautiful, scientifically, progressed clinical experiment in the marketplace where a multifocal cornea with a central island of 2 diopters resulted in 12% of patients losing 2 lines. With the same system, they reduced the ad, made one eye a little bit more myopic, and increased the safety to only 5% of eyes losing 2 lines, which of course isn't satisfactory because that's the ssame as a Vizix 2020B in 1995. So they went and reduced the ad even further in the dominant eye so that binocularly there was no loss of lines, but obviously monocularly there probably was. So multifocality in the cornea has the same disadvantages of multifocality in an IOL. And so we know that there's a high chance of night vision changes, reduced contrast. Some patients are not going to adapt. And of course, if in an IOL situation, what are you going to do for an enhancement? Because you're obviously going to do laser, in which case, why don't you start with laser? So let's go to the monovision side. And again, I'm just reviewing this. Everyone knows that one eye is set for distance, one eye is set for near, and that unfortunately in monovision, the intermediate doesn't work because of the amount of ad required for near vision. Now, those are the challenges, right? Intermediate vision loss, actual neural subtraction because of the confusion between the eyes or in the brain, loss of stereo acuity, loss of the fact that you've got summation when you have good binocularity, and that only 50–60% of patients tolerate it. The thing is that if you reduce the monovision, as Graham Barrett called monist monovision, yes, you improve on all of these challenges, but then you don't get the intermediate vision. The Pardon study in 1990 is really a critical study to understand. What we have here is the amount of anisometropia along the x-axis and the summation in the vision. So if you have binocularly in 20/20 vision in both eyes, you will have, monocularly, binocularly, you'll see 2016 or 2012 because of its summation. That summation decreases, but then it increases once suppression occurs, because obviously if there's suppression, you don't get neural subtraction. And neural subtraction is what's called crossblur and discomfort and asthenopia. But we lose the summation loss, and we only have the vision of the single eye when we don't have both eyes. So understanding that curve is important, and understanding that it is well understood that if the anisometropia is more than 1.5 diopters, then you don't get stereo acuity, and actually you can break the stereo acuity and you may never get it back, even if you stop the monovision. So in the end, monovision also has these compromises, which is that not everyone tolerates it, and also that you have to kind of choose between intermediate or distance vision. And so now we come to what is the industry's, like everybody has converged on the same solution. The same solution of using spherical aberration as the aberration that is best tolerated to increase depth of field. And why is this? It's because spherical aberration is a natural aberration. It occurs in the lens, it increases with age. Obviously when the lens becomes rounder, when you accommodate, there's more spherical aberration, so it increases depth of field. This is something which is built into the system, right? And it is not multifocal. It is not more than one focus in the same eye. So perfectly focused systems, yeah, they're aspheric lenses and no aberrations, no spherical aberration, but then the depth of field is very, very short. Whereas if you disseminate the focal point by spherical aberration somewhat, you actually get increased depth of field. This is an exact replica, sort of experiment, I should say, of showing you what defocus does, and you're all in the audience looking at this, and you can see that at -150, your vision's 2200. And you can't see letters. Whereas the same defocus with spherical aberration means that you in the audience are looking at this, you can detect those edges now. And that's because the brain has filters for spherical aberration. And so once you've looked at this this is the image of a retina that is with the added spherical aberration on a plano eye and a -150 eye. But because it's in your brain, the vision in the brain in each eye is actually much better, and the brain is putting together two very similar images once the neural processing has occurred. And that is quite different from putting together two images that your brain can't process, and that's monovision. So when we started describing this, the labs around the world that had adaptive optics systems were starting to check, experimentally, if you put spherical aberration in front of the eye, how does the depth of field change? So non-surgically. And very elegant study by Carolina Rocha, where she showed that increasing spherical aberration, both in the positive spherical aberration and the negative spherical aberration directions increased depth of field. And you can see that they were getting about 1.5 diopters of depth of field. And there was a zone where you get a linear increase in depth of field from the amount of spherical aberration induced. But if you go beyond that amount, it becomes toxic. And we showed this in our very first publication, which was to do with fixing night vision disturbances and finding that if we reduce the spherical aberration to a 0.6 level, contrast sensitivity recovered. Whereas, if it was above that, then the patient suffered with night vision disturbances. So everyone's understanding this theoretically. And in our case, we realized that we couldn't change the depth of field more than 1.5 diopters before getting into the toxic range, losing contrast. And so we needed to use a little bit of anisometropia to get the near and the distance all together. And this creates effectively a blend zone because the distance eye has a depth of field of 1.5 diopters, which at the near end extends to -0.75, and the non-dominant eye, which is set to nominally to -150, at distance it has a vision as if the eye was -0.75 also, but at near it has vision as if it's -225. So that's the center and that's the center. So the blend zone is because both eyes have similar acuity, and it's 0.75, which is sufficient to identify edges and fuse the two images from the two eyes. So all of these monovision challenges are actually eliminated by adding spherical aberration to a -150 defocus. And this is not the same as modest monovision. It's not monovision. It's binocular vision because both eyes have sufficient information that the brain can put the two eyes together. And so that means that this picture of having intermediate blur and very poor distance in the non-dominant eye means better distance in the dominant eye, excellent intermediate vision and near, and distance vision, better distance vision in the non-dominant eye. So it's in the dominant eye, sorry. So I'm showing you here how there is neural summation. You'd expect a -150 eye to see 2100, but actually 80% of our eyes are seeing 2060, and this is 395 patients, emmetropes, hyperopes, and myopes. And you can see that overall 92% of them were seeing 20/20 in the distance eye, and this went up to 96% binocularly. In other words, the blurred 20/60 eye is giving more summation and giving better distance vision in the brain, summation. And we've also demonstrated that stereoacuity is maintained, that we have at least 3/4 of the patients with at least 100 seconds of stereo. So we're maintaining stereoacuity, proof that this is binocular vision. And so the question then is, well, how do you do this? Well, the answer is you have a software that you push a button on, and you do LASIK. It's incredibly simple. How do you qualify the patients? Well, basically 97% of patients pass the tolerance test that we devised that takes 2 or 3 minutes. So it's a 2 to 3 minute test on a chair, and then you just do LASIK with a software that calculates everything in the background. And you end up with these results, which I've presented a million times. These are our own papers with over 100 patients with 1-year follow-up, showing levels of vision that you could never expect from intraocular lens calculations. Maybe you certainly expect it from a light adjustable lens, but not from any AI or whatever you're going to use to do lens calculations, because the ELP is such a messy subject. But incredible amounts of patient visual independence with no loss of lines, no loss of contrast, and around the world, everyone's starting to publish this now. There are apparently, according to Zeiss, over 320,000 of these have been done in 250 centers. So it's not widespread, but it is out there. And we have this beautiful publication by Sheetal Brown and Sri Ganesh, where they show that the amount of patient satisfaction is huge, but look at the spectacle independence. it's nearly 100%. And the dysphotopsia rates is nearly 0. The same thing again from Andrea Russo in Italy. Huge patient satisfaction. Well, that's easy to get because you under-promise, you over-deliver, you're fine. But again, massive independence from glasses, something that's way more than you would expect with multifocal optics, and incredibly low dysphotopsia rates. And that's because there's no loss of contrast. So in the end, and you know, maybe this table is biased, but if you look at these criteria and you look at the disadvantages of each methodology of correcting presbyopia, either multifocality, monovision, or spherical aberration with extended depth of field, it's clear that we have the least disadvantages with the center option. And so, yes, you know, these IOLs now with extended depth of field are coming out, and spherical aberration being used to increase depth of field. So then the question then is, well, can you do it, what should you do? Should you do it with an IOL or on the cornea? And the answer is, it's easy to decide that if you look and measure lens transmission. Because obviously, a patient who has a cataract and you put a multifocal in is going to be super happy because you're increasing their transmission. But somebody who has good lens transmission and you decrease their transmission to 85%, which is the best trifocals out there, maybe it's, you know, there's a chance that they're not going to like that change. So this idea of treating these two patient groups in the same way, you know, it can be a problem. So when we look at actual cataract and, you know, this gray zone of 60 to 70, you know, in Europe we get cataracts way, way later than you do in India. But if we just look at the younger presbyopes, so we're not arguing about the other stuff, the younger presbyopes, remember that 30% of people in Europe develop cataract, not everyone. And so a lot of people die without having had cataract surgery. So the excuse of doing the lens surgery just because you might get a cataract is not great. And remember that in Europe, 1 in 6 patients develop macular changes. So you can have a normal OCT at the age of 50 and develop, you know, severe macular changes, and you have a multifocal in your eye. Not a great situation. Also, of course, intraocular surgery invites the possibility of the more catastrophic complications, and we know that retinal detachment rates are much higher in people in their 50s having phaco than people in their 80s, 4 or 5, even 20 times in one study. We also know that a corneal astigmatism is relatively stable until we're 40, and then from 40 to 80, it continues to change. We know that from large studies. Here's a study of for 4,000 eyes, showing that a third of eyes change by 1 diopter of SIL in 5 years after the age of 40. So the idea that an IOL surgery is permanent vision is not true. It's permanent lens replacement, but it's not permanent vision. We go over this lecture of 15, 20 minutes in about 8 hours when we teach this formally, and when we started teaching it, we found that surgeons sitting in the audience were starting to ask to have it done on their own eyes. And so it was an interesting experience for me because 10 years of talking about this on stage in short talks, and then setting up a course where we talked for a whole day about all the scientific background. Bought a pair of glasses. I never owned a pair of glasses. And I went directly to surgery. And I now, you know, see like I did when I was a kid. And my refraction is minus 175 in my non-dominant eye, but I still see 20/50 in that eye, which is why I have, you know, my superb distance, intermediate, and near vision. But I also have 40 seconds of stereo, and my contrast is still very, very high. So that's me at Club Med when I was 20 years old, and I might not look the same, but I certainly can see the same. So overall, when we look at the different approaches to presbyopic correction, we see that the least disadvantages are obtained by spherical aberration, increasing depth of field. And whether you do this on the cornea or lens should depend on the health of the eye, the amount of cataract, and the fact that laser refractive surgery is enhanced as many times as you want over a lifetime, and that once you've got that spherical aberration in the cornea, then you can use a monofocal, high-quality, low PCO rate IOL, and not a premium diffractive lens, to correct the cataract later and still maintain the benefits of the EDOF on the cornea. So thank you very much for your attention.
Thank you, Professor Dan. It was really very nice talk from you, and we like to have audience sitting here. If they have any questions, we can ask him. You know?
Yeah, hi. Dan, that was fantastic. So, are you still playing the saxophone? I believe you are.
Yeah.
Perfect.
I hope that'll be the last thing I do.
Yeah, no, that's how they want to go. See, there are two things which you touched upon, which we also thought was like lots of patients in which a unilateral cataract done, they got N6 and 6.6 with a aspherical lens. We used to call it a pseudo accommodation. I mean, that's what, we don't know what it is. I mean, I think it's a great term. But what you said about was the brain filters, and they filter the spherical things better. Can you just elaborate on them? And are there any studies which you can pick up which patient are going to respond that way? Because I had a family in which I did 2 patients. They were N666 with a aspherical lens, but the other members were not. And they were all from the same gene pool. So which patient can you decide? I mean, can you have a pre-op test up? I'm talking about the cataract surgery, that which patient will go this way and which will not.
Yeah. We observe a similar thing in presbyopia, in that some patients get I have it. I have total spectacle independence. I can see the pixels on my screen at this distance, and I'm in focus continuously. As I'm going back, I'm not losing any focus, and I'm still in focus, and I'm still in focus here. I'm totally in focus. And that's because one eye takes over from the other, and the spherical aberration is giving me that exact blend that I showed on that diagram. Now that we do have, I have patients who have the right amount, I can think of right now, a patient who's, he's like 6'2", very slim, 6'2" guy. He was a -8. I did presbyond on him. He was exactly plano and exactly -150. And his intermediate was not as good.
Yeah.
And he complained of it. And I couldn't make him -2 because then he'd really lose intermediate. And so it was really, I think you're right, there are patients. But if you look at the study that, the results that I showed from the original studies from 10, 15 years ago,
right.
the vast majority of patients have N10 at computer distance.
Yeah, that's right.
So you're right about that. And by the way, I had that experience when I was a resident at Mount Sinai in New York, where it wasn't aspherical lenses, it was spherical lenses.
Yeah.
The SA60, which was, the big popular lens in the mid-90s, and I had a patient who was plano in both eyes, and he was reading the newspaper. And I asked my attendant, what's going on here? And of course he said pseudo-accommodation.
That's what.
Like, oh, that's okay then. It took 10 years to find out what exactly that really was.
Yeah, that's perfect. So second thing, when you said you see the transmittance of the light through the lens, what we do here is we do an eye trace to see the DI value. DLI value, if it's more than 10, I mean, we know we're going to go and operate these ones. Is this a protocol which you're also following there?
Absolutely. Well, although we don't use the eye trace, we use the HDA, the HD analyzer.
It works the same way.
The ocular scatter index.
Yeah, okay.
And obviously, if the ocular scatter index is in the green,
right.
which is up to 1.0, then it's not a lens surgery for us at all.
Right.
If it's in the yellow, we discuss it, and if it's cataract, well, it's cataract. Cataract surgery is cataract surgery.
Right, perfect. How many lenses have you taken out for the patient having the rings with the old Symphony or something? We had to remove certain lenses from certain eyes because they could not tolerate the rings. And they were high-end people, I mean, bureaucrats' wives. They read somewhere that this is the best lens. They got the lens. We did the surgery. We waited for 6 months, no neuroadaptation, nothing happened. We had to remove them. So does it happen in your hand also?
Listen, I've been very fortunate. I mean, I'm talking about my personal experience. I've been very fortunate because the reason why I was desperate to develop a presbyopic solution that was not lens-based was because I developed this, remember, when we were talking about the array lens and then the resume and restore, and that was the 2000s. And for me, that was an unacceptable level of unhappy patients. There was too many. And so I was desperate to find a different solution. So fortunately, for me in my practice, I don't have that issue because I never used diffractive IOLs. For us, no cataract means corneal surgery, presbyon, and when they get a cataract, it's a monofocal IOL. If there is a cataract, we use spherically aberrated lenses, the older lenses, in fact, the ones that cost nothing. The companies are very angry because they don't like the fact that we don't buy expensive IOLs. We use the cheaper IOLs, have more spherical aberration in them. And so in my practice, I've been very fortunate in that I kind of missed the whole diffractive, extravaganza. But you're right, there is no such thing as a diffractive lens that doesn't have patients that eventually need explantation because they can't tolerate it.
That's right.
They're suicidal, even though you tell them that there's a very high risk of the lens exchange, they'll still do it.
Right.
But let's be clear, some of the EDOF, so-called marketed EDOF lenses of today are not EDOF lenses. They don't have continuous optics. They are segmental refractive multifocals. And one of the examples is the Vivity. That is not an EDOF lens. It has probably, I think, 3 different focal areas. There's a ring, a central, and a peripheral. And those are 3 different. I have a patient who came in, I didn't put it in, who was really suicidal because of he felt that he was looking through a tunnel. And he had exquisitely performed phaco. I mean, the surgeon did an incredible job. The patient was planar in both eyes, plus a quarter, minus a quarter in both eyes. But he was really unhappy with his vision. He was 53 years old. I didn't want to just tell him that he could have had a corneal procedure that would have avoided all this, but he ended up with a lens exchange. So beware of marketing, because marketing overpowers the actual optical science sometimes.
Okay, thank you.
Last question, 1 minute.
Thank you, Professor Dan Reinstein. It was really wonderful
to
have you.
undergo presbyopia refractive surgery at the age of 57. At the age of 58, person is a doctor, he or she wants presbyopia refractive surgery. Is it advisable?
Can you?
Sorry, I didn't quite get the question.
At the age of 58, if the patient is a doctor, he or she wants presbyopic refractive surgery. Is it advisable?
Of course.
Okay.
I mean, why not? I mean, my father was 74. He was plus 175 minus 1 in both eyes. And I did presbyon on him in 2005. And he lived another 10 years before he needed a cataract in one of his eyes. And he was spectacle-free from 74 until 89 when he passed away. So it's not an age-based thing, right? It's nothing to do with age. It's to do with lens transparency, as we just heard. You can either measure the OSI with an HDA or with a Tracy, or obviously evaluate the contrast. Because if you measure contrast sensitivity, you have a really good way of determining whether the lens is causing loss of vision.
Okay, I think that's absolutely correct. Maybe the Indian eyes, you get older faster. Clarity of lens may be little challenging even at a 58 years, There, I think you rightly pointed out, we need to assess the lens clarity, the transmission, contrast, and DLI to really think of doing some sort of laser vision correction in these cases. Thank you, Dan, for being with us. It was a pleasure to have you in this morning, and enjoy the entire day. I know that London has a beautiful day nowadays. And on behalf of Delhi Ophthalmological Society and my own institution, that is All India Institute of Medical Sciences, we'd like to thank you and wish you to see you in physically during the EACRS. Thank you again.
Really what I would like is to be physically at the All India Institute.
we'll invite you. Don't worry, we'll invite you there. Okay, good day. Enjoy. Yeah.
We continue with our mini symposium, and I'll invite Professor Rohit Saxena to speak on the management of myopia.
Thank you, members of the dais, Delhi Ophthalmological Society, to give the opportunity. Coming after this absolutely wonderful talk, it can be a very major challenge. I'll try and continue with discussions about optics and how to correct optical issues. So I'll be talking about childhood myopia. We know that it's now becoming really an epidemic, and including India, we can see that there is a huge increase not only world over, but even in India. And we did this meta-analysis. We found that even in rural areas, this thing is beginning to be a problem. And there has been a jump in the last decade, even in rural areas, from about 4.6% to 6.8%, which is a major challenge for all of us. So our decision to intervene is to be based completely on the risk factor identification of a child. So first time a child comes and is prescribed glasses is not an indication to talk about managing progressive myopia. So we need to understand there are two things to it. One is myopia, that the child has a refractive error that needs to be corrected with spectacles. The other thing is that does the child have progressive myopia, which needs to be managed in other ways. So the key intervention decisions for managing or preventing progression of myopia would be the risk factor identification, which would be the baseline refractive error or the magnitude of refractive error the child comes with, the age of onset of myopia, the genetic influence in the form of the parental refractive error, one or both parents are myopes, and the visual environmental considerations. And as I mentioned, it's important to document myopic progression. The risk factors, one would be what is now called as a pre-myopic child. Now we have a pre-myopic child who is lower hyperopia for that age-matched normal. He's not a myope at the moment, but for about 6 to 7 years of age, which is the time when myopia is beginning in children, less than 0.75 diopters of hyperopia is considered pre-myope, along with the other risk factors, environmental risk factors. Younger the age of onset, more rapid it has been seen that the myopia progresses, as also the longer duration for which the child will be progressing, and therefore is ultimately going to have much higher levels of myopia. We talked about parental myopia, and if both parents are myopic, there is a 3 times risk that the child will have progressive myopia and reach high myopia by the time he is a teenager. Females, for some not very clear reasons, have been shown to be faster progressors, possibly related to their being in closer indoor environments as compared to males. And ethnicity, East Asians are more progressors. The Caucasians are supposed to be less, and we lie somewhere in the middle. The visual environment is the next most important risk factor, and children who become myope spend much less time in outdoors. And also is an independent risk factor is the amount of near work. So there are two very important strong associations. One is the close distance. So the closer the distance, more is the factor influencing the likelihood of progressive myopia, and also duration. So reading continuous periods of time, more than 30 to 45 minutes, is again in many studies an independent risk factor for progressive myopia. Finally, the recent understanding is anomalies of binocular vision and an accommodative lag. Many of these progressive myopes have esophorias, accommodative lags have near and reduced accommodative facility. The preventing onset of myopia, identify the pre-myopic child, low hyperopia, one or both parents are myopic, spend less time outdoors, increase near activity and binocular vision disorders. We manage that. Currently, there is no, at least in India, an indication to treat them pharmacologically or optically. So we correct their refractive error, we increase awareness among parents and children, do risk factor modulation, so we increase their outdoor activity, control or modify or moderate their indoor, particularly near activity, and at the moment there is no clear indication for aggressive interventions, including pharmacological, or those studies are underway. To prevent progression, again, it's very important to have education, teaching, and understanding of the problem that we're dealing with. a cycloplegic refraction, particularly the first time, give appropriate glasses the first time, whatever, irrespective of the magnitude of myopia. Do not undercorrect. There is no evidence that either undercorrecting refractive errors reduces the risk of myopia. And identify whether the child is progressive or not if you want to take a decision on intervention. In the absence of that, be careful before you start any treatment. The other most important thing that now we understand is that myopia intervention is designed to prevent axial elongation and not refractive error change only. So an axial length measurement is extremely important whenever you are measuring this, along with other things like ocular surface and pupillometry if you're thinking of atropine. Your treatment strategies has to be based most importantly on the economic status of the child at the moment, because now optical interventions are available like defocused lenses, the Halt lenses, and of course contact lenses like ortho-K and soft contact lenses. So just to explain to you how these spectacles work, the basic structure of the back of the eye is an oblate change, and we know that if you give single vision glasses, they optimally correct for the center, but there is a hyperopic defocus in the mid periphery, which is said to be responsible for the myopic focus that these children are having. And the new spectacles are now designed to change that hyperopic focus to defocus, to a myopic defocus. So some of them, of course, initially there were like ring segment ads in the periphery, but they reduced the field to such an extent that children were extremely uncomfortable. So now the modifications are these DIMS spectacles, which in the mid periphery have multiple small lens sets that ensure that 50% of the area provides an ad and the 50% area provides normal distance correction. So the child's field, and when he looks through the edge of the lens, is not significantly affected. So this is the DIMS technology by Hoya. They have a fixed peripheral ad which is 3.5 diopters. The Stellis lenses which are by Essilor have a progressive additional change as you go into the periphery. So they bring about a volume of myopic defocus, which they say is more efficient, although at present there is no evidence to say that either of these lenses are better or worse. You have prismatic bifocal lenses, which have shown to be better in children who have esophorias and accommodative lag. Of course, soft contact lenses and ortho-K, not extensively practiced in India, have its proponents, have shown to be good, but of course you have corneal related risk issues. I'll just quickly touch on atropine, which is the most prescribed treatment currently available for myopia. Across the world, multiple studies have done that shown its efficacy, including one from our center, which was a part of a multicentric trial. I'll just bring to you the complexity involved in atropine treatment. Just this month, you had 2 publications from America, both in JAMA, back-to-back in 1 year. The first study showing that low-dose atropine is effective in the Caucasian eyes, and the second study showing no significant difference in atropine in changing in progression of myopia. So we know that our understanding of myopia therapy is still underway. One of the possible reasons for this dichotomous result could be that in a low progressive population, which the Caucasians are, a low effective intervention, which low dose at 1.01% atropine may or may not give you that great results. So therefore, this dichotomous result, which of course we'll get to know as we go along. One of the other things that we realized was that we are treating children with atropine, and we know that atropine always, however the dose, will bring about change in the anterior segment refractive error. And this was a recent publication that we showed that part of the effect that we attribute to atropine is because of the anterior segment change, and therefore the earlier studies that were talking about the dichotomy between not so much effect in axial length and fairly good effect in refractive error could partly be explained by the anterior segment change of atropine and not its effect on axial length elongation, and also can explain the rebound effect that we are seeing with atropine. So it's important to keep this in mind. Lastly, lifestyle change. The single most important impact you can make, increase outdoor activities. It has been shown that it is significantly impacting if you do up to 2 hours of outdoor activity in mesopic or photopic light. So you need to be between dawn and dusk, and not after or before that. And of course, visual environment modifications. It's very, very important to teach children for this. So it's important to decide based on progression and of course the affordability of all these various investigations that are there. So you need to finally follow up a child, see how well he's doing on one intervention, whether you want to change or add an intervention, so that you're able to control the myopic progression, which will proceed up to 15 to 16 years of age. And now we are, of course, seeing it to be much older and up to 20s also because of the increased near work. And treatment may be stopped or switched if it is not controlled, if there is poor tolerance or compliance or safety issues. Huge options now available with different efficacy, so you need to choose in what patient you want to manage. And finally, we know that increased awareness in the next generation is very important. We know outdoor activity helps, multifocal spectacles help, atropine drops help, soft contact lenses and ortho K are also impactful. So choose what is in the best interest of the patient. Follow up, particularly using axial length as a follow-up. Thank you very much.
Thank you, Professor Rohit. Now I invite Professor Vinay Gupta. He will be talking on ASOCT in glaucoma. And after that, we can discuss.
So after that is lunch. So yeah, I'll be talking about the anterior segment OCT with glaucoma, and primarily the work that we've been doing over these years in anterior segment imaging. So classically, the ASOCT was used for angle closure, where they wanted to measure the amount of occludability in angle closure. And since then, it has really helped in understanding the pathogenesis of the disease, which is angle closure, where they found that the lens was also playing a big role, and the lens vault could be measured and could be the cause of angle closure. So there are a lot of measurements that have been done with the help of ASOCT when you're trying to measure the angle and the anterior segment parameters. Our work was mainly focused on the high definition ASOCT, where we showed that on high definition you could even visualize the trabecular meshwork and the Schlemm's canal in open angles, and that in primary open angle glaucomas also it was important to visualize these structures because they could prognosticate the treatment options that were given to these patients. So here you can see an open angle, but also you can see on ASOCT that there is a very thick membrane which is occluding the angle and causing a rise of intraocular pressure. Another patient, you can see there's a high iris insertion, and you can see that on ASOCT. But what is interesting is that you cannot see the Schlemm's canal. So the Schlemm's canal, which was supposed to be here, if you can see in both the pictures, is just not present. So there is an absence of Schlemm's canal. So although you can see gonioscopically the angle dysgenesis, but you cannot make out the presence or absence of Schlemm's canal just by looking on the gonioscope. But on a high definition ASOCT, you can actually see the absence of the Schlemm's canal, which indicates a very severe anterior segment dysgenesis. And this is what we published when we saw a large number of congenital glaucomas, juvenile glaucomas, and adult open-angle glaucomas, that the absence of the Schlemm's canal was majorly present in congenital glaucomas, and almost 40% had an absent Schlemm's canal in juvenile open-angle glaucomas. So you can see here a good Schlemm's canal in a normal angle, normal eye, but you can see there is an angle dysgenesis in this eye, and there is an absence of Schlemm's canal. So this was helpful in our understanding of how angle-based surgeries can be prognosticated. So when we did selective laser trabeculoplasty, which is notoriously ineffective in a lot of our eyes, we realized why this was happening. Why was it that certain eyes were responding to SLT, whereas the other eyes were not responding to SLT? And when we looked at the ASOCT, we found that the eyes which had a severe angle dysgenesis actually did not respond, whereas those which had a good outflow facility and good outflow channels actually responded to the selective laser trabeculoplasty. And this work was done by one of my thesis candidates, Dr. Toshit Vaishnav, where he showed that the presence of angle dysgenesis, which was either presence of this abnormal membranes or absence of Schlemm's canal, could be highly predictive of the selective laser trabeculoplasty response. So then we went a step further. We started looking at angle dysgenesis and the effect of mutations of the known genes for glaucoma, and we found that there are certain genes which are causing certain changes in the trabecular meshwork, and that the ASOCT in high definition can pick up these changes, which can also be fed into artificial intelligence, and we can pick up angle dysgenesis based on ASOCT and correlate them, and this paper is under publication. Not only that, it led us to understand something very interesting where we found that patients with congenital glaucoma having only one eye affected, we wanted to see why is it that despite the fact that they had mutations, only one eye was affected, whereas the other eye, despite the fact that it had angle dysgenesis, did not develop glaucoma. And we found that the Schlemm's canal anatomy in a lot of these eyes was very strange. You can see that the Schlemm's canal is actually opening into the anterior chamber. So this is for the first time we showed that these anatomical variations in the Schlemm's canal could be predictive in some patients for the development of glaucoma. Apart from that, the ASOCT has helped us understand the bleb morphology and interventions in certain bad-looking blebs like this, where we had intervened, and over a period of time you can see how the bleb from cystic has become flat. So that again is an important use of ASOCT. The intraoperative OCT has also helped us in managing children with totally scarred white corneas, where we wanted to do a glaucoma drainage device, and we needed to know where to place the glaucoma drainage device, and therefore it has an intraoperative use also. The OCT angiography we are recently using after GAT, and Shika has done a lot of work where she has shown that before the surgery the channels are all closed in congenital glaucoma, as you can see the upper two images, whereas in the lower two images you can see that after the angle surgery the outflow channels actually open up. So this is also very interesting. And another thing that has recently been published, where Shika also showed that in cyclodialysis patients on OCT angiography there is an opening up of the lymphatic channels, and that these lymphatic channels contribute to the hypotony which is caused by the cyclodialysis. So these are some interesting works that we have been doing recently, and I would like to conclude that ASOCT, apart from angle closure disease, can be really helpful in understanding the pathogenesis of open angle glaucomas, congenital, juvenile and adult onset open angle glaucomas, and would be used in near future to predict the success of angle-based surgery. And of course, as the resolution of the device increases, there would be more intraoperative application to the device. Thank you.
Thank you so much, Dr. Vinay, for that wonderful presentation.
Thank you everyone for coming in huge numbers, and we have a lot of stalwarts of Delhi Ophthalmical Society here, and we would like to appreciate them. So first I would like to invite Dr. Harman's Lal sir on the stage, current President AIIMS, and I would like to request all of you to give him a round of applause. Dr. R.B. Jain sir. नहीं सर R.B. बोला Dr. Subhas Batheria sir. Dr. J.C. Das sir. Dr. J.L. Goyal sir. Next, I would like to invite Secretary Sir for early bird prize. No, he will announce that. Dr. Arun Sangal, sir.
Mr. Ashwini Kumar, sir, please. Thank you so much for coming.
Secretary sir. Early bird. President sir and Secretary sir, please. Early bird, 20 early bird. Thank you. नहीं नहीं
Sir, Dr. Harbans Lal, sir, announce.
Mic.
Okay, so on behalf of the President AIOS, Dr. Harbans Lal, sir, I would like to announce that under his stewardship, a unique activity has been started, and that is AIOS Yog Shala. So for all the All India Ophthalmological Society members, there is going to be online classes by none other than Mr. India 2000, yeah, he's Mr. India. Sir will tell the details. And they're going to be there from Monday to Friday from 7:30 onwards.
So I've been actually personally attending the yoga classes for a few years, and I had a wonderful experience as a, whether it's the physical fitness or the mental fitness. So we thought we can have, there'll be YouTube link will be sent to you shortly. It will be Monday to Friday, 7:30 to 8:30 it will be live, but you can watch it. Evening 7:30 to 8:30, but you can watch it anytime. That means if you don't have a 7:30 to 8:30 time, you can do it next day morning, afternoon, evening, Saturdays, Sundays, because it will be there. For you, it will be live whenever you open. But if you actually on live, then he can ask you certain questions, you can reply, and the chat box will be open at that time. So we will like you to join in large number. I'm sure it is going to benefit one and all. So thank you, and do join and check it out for yourself.
So now I'll be announcing the names of early bird registrations. First is Dr. R.K. Duves, Dr. Arun Baveja, Dr. Shreya Banwal, Dr. Aryan, Dr. Sanjay Dhawan. Dr. B.S. Seth. Photographer. वहाँ से ले Dr. Punita K. Sodhi. Dr. Nikuni Garg. Dr. Rupali Sharma. Gaurav Kumar. Navjot Kaur. Ashok Agarwal. Dr. O.P. Anand sir. Dr. B.P. Gupta sir. सर तो चले गए. Dr. Satish Mehta. Dr. Gagan Bhatia. Dr. Shalini Kumari. Dr. Kamlesh Kumar. Dr. Subhash Dadia sir. Dr. S.K. Verma. Dr. Narendra Bhaskar. Dr. S.M. Batheria. Dr. Mrinalini Singh. Dr. Ishita Agarwal. Dr. J.S. Bhalla. Dr. Avneesh Singh. सर लेते और बार लेते. Dr. Shishima Agarwal. Dr. Ankur Singh. Dr. Gyan Goyal. Dr. Sandhya Makhija. Aparna. Dr. J.L. Goyal. Dr. D.J. Pandey. Dr. Nausin. ऐसे कुछ लोग मिसिंग है. Not anyone. कितने? 3 है सर, आप किसी को. हाँ.
और दिखाओ भी डॉक्टर शरद लखोटिया. और कौन से? डॉक्टर संजीत साहा. और डॉक्टर सुग्रीव वाली. आ जाओ.
So there are just 2 announcements. The next monthly meeting is going to be held at RR Hospital, and that is on 27th of August from 11 to 1, and we are going to have our midterm conference of DOS at Hotel Ashok on 2nd and 3rd September. So please register in large numbers. We are having a huge and very enthusiastic response. Thank you, everyone.
Thank you everyone for making this grand success. All of you are invited for lunch on the first floor, all of you.